Thanks, good morning, everyone. Welcome to the ACD members and the CDC leadership. We have an action-packed agenda today. We're going to start in a moment with a presentation from the CDC director, and then there'll be following discussions on public health accreditation, CDC activities regarding mental health and drug overdose. We'll have some presentations from Moving Forward and Health Equity, CDC's forecasting for CDC's new Center for Forecasting and Outbreak Analytics, and then we'll conclude the day with a vote on a potential new working group on communications and public trust. So we have a busy agenda in front of us. Let's go ahead and get started. Roll call is the first thing we do, but let me just say for the record that November 14th, 2023 ACDA work group minutes have been finalized and placed on the ACD website. And today marks the beginning of the third year of our new ACD. Exactly 2 years ago today, we had our first meeting. The date for today's meeting needed to be changed, and so we have a mix today of in-person and virtual attendees. Let me go around our two tables, real and virtual, for a roll call, and folks can declare at that time whether they have any conflicts. I'll start, David Fleming here, and I have no conflicts. Jill.
President Jill Taylor, and no conflicts.
Julie.
Morning, Julie Marita, no conflicts.
Octavio.
Present, no conflicts.
And then virtually Rhonda.
Good morning, this is Rhonda Meadows, no conflicts.
And Daniel.
Morning, Daniel Dawes, no conflicts.
Monica.
Good morning, Monica Valdez-Lupi, no conflicts.
I think Monica is in Hawaii, so morning is a gracious term for where you are. Thanks for being here, Monica.
Thank you.
And then I think Josh is on. I don't see him on the screen.
I think I'm here. Can you hear me?
I'm glad that you're there, Josh. Yes, we can hear you.
I was rescued. Thank you very much. Josh Artstein, no conflicts.
Okay. And has Rachel been able to join us yet? I know that she was ill. I'm sure she's on her way. And importantly, on somewhat of a personal note, it's a delight for me to welcome our newest member to the ACD, Dr. Helene Gale. Dr. Gale is president of Spelman College here in Atlanta. She's a pediatrician, has an extensive public health resume, including leadership positions at CDC, at the Gates Foundation, as the CEO of CARE, just to name a few. And more importantly, I've had an opportunity to see her in action in multiple settings because I've kind of followed her around in a couple of those. And so, Helene, it's great to have you on the committee. Welcome. Any words of introduction would be appreciated and a declaration of conflicts.
So no conflicts to start with. And first of all, it's wonderful to be here and wonderful to be with everybody. You know, my life is totally crazy, out of control, too much going on. But when I got the call to do this, I couldn't say no. CDC was my first professional home. I was here for 20 years, and it is part of what made me who I am. So I really felt strongly that if I could be helpful at a time that I think is really critical in the life of CDC, that I would do what I could to give back and be as helpful and supportive as ever. And it didn't hurt that old friends and colleagues like
Now, what do you mean by old?
long-standing. Yeah, I think we started CDC within a year of each other, so we really have known each other all of our career. Julie Marita, who I worked with in Chicago very closely, Daniel Dawes, who we overlapped when he was at Morehouse. And so, you know, it's also coming home in a very personal way as well. So this is great, and I'm just thrilled to be part of this.
Thanks, and once again, welcome. And we're really looking forward to your participation in the committee and catching up on old times. The good news is we have the required quorum, so we can go ahead and proceed. As a reminder, particularly for the ACD folks joining us virtually, please keep your camera on as much as possible and raise your hand if you'd like to make a comment. If I don't see it, feel free to wave your hands on the screen and or just speak up. On a more somber and much sadder note, we're missing today one of our longstanding ACD committee members and a friend and a colleague to many of us. I'm speaking, of course, about Dr. Ada Adamora, who passed away earlier this year since our last meeting. And I know I speak for all of us in saying that Ada's presence will be deeply missed. I actually didn't know her before serving on the ACD, but I was fortunate enough to have her on the same health equity working group that I was on. And in that capacity, I got to see her in action. She was a smart, clear, good listener, a wonderful contributor. And I think I'd add not shy to her many list of wonderful qualities. I also had the good fortune to talk with her a couple of times one-on-one about some early conversations we were having about CDC communication and CDC leadership and communication. In that sense, I know her thinking helped inform the work group that we'll be voting on today. And I feel that we're really fortunate to be able to, that she was able to leave that legacy. Deb, would you like to say a word or two?
Yeah, thanks, David. I really, echo the sorrow about losing her. When David and I were trying to stand up the communication work group, we spoke with her several times, and she had mentioned she had an illness, but she would do her best to champion and move the work forward. And I also had the great honor and privilege of getting to know her. We were both in the COVID classes of the National Academy of Medicine induction. And so got to spend a weekend with her in DC when we were being inducted and got to know her there. She's just really a pillar of light, has done a lot of great work in infectious disease, health disparities, and that bright light is out. And, I think I've seen so many wonderful remembrances of her online, and I'm just honored that she was part of our group and thankful that she was able to share her wisdom with us.
Thanks, Deb. So, Ada, we will miss you. And because you care deeply about health and public health and equity, I think if you were here, you might suggest it was time to get on with the meeting. And so we'll honor that in the best way possible, because it's now my great privilege to again welcome the CDC Director, Dr. Mandy Cohen. The director's update is a core part of these committee meetings. And so, Dr. Cohen, it's a pleasure to have you here, and you have the floor.
Thank you, David, and great to be with you all this morning. I was glad to see everyone at the event last night as well, that I thought was incredibly powerful. So thank you, Julie, for doing a terrific job moderating that conversation. I'm thrilled, Dr. Gale, that you have joined. As I shared earlier, and you had said, your life is so busy. I was like, there's no way she's going to be able to say yes, but I was so grateful. I didn't realize we had a ringer in our chair to bring you on board, but I'm really looking forward to working closely with you, learning from your experience here at CDC and then outside of CDC, and how we can take both of that to make the CDC as strong as possible. And then just to echo, David, your words about Dr. Adamora, as you know, fellow North Carolinian as well. So knew her work from North Carolina, and a huge loss. Just a huge loss, but you were right. She would want us to get to work, but she was just a wonderful human being in addition to just her incredible professional contributions. So certainly greatly missed. But what I wanted to transition and have a conversation with you, one is just like a very quick look back at the few months I've been here in 2023. So I've been here 8 months now. And then how we're thinking about looking forward to 2024, and talk a little bit about the committee that we've asked as we've thought about what is it that we need continued work and help on. So, looking back at the last 8 months, I'm really proud of the work that I see across CDC. One, recovering from a historic crisis that this organization had to respond to, and was in like just the most intense readiness posture that you could imagine. And honestly, recovering from that, learning lessons from it. I see that happening every day when we're not done, but I think you could see them happening in some of the successes in the second half of the year. I saw them in how we responded to the fall and winter respiratory season, and operating differently and operating as one team across CDC as we did that work. So it wasn't just the COVID team and then the flu team separately and the RSV team. It was everyone, and it wasn't even everyone who works on respiratory viruses. It was everyone at this agency pulling together, from data to lab to workforce to our communications work, our partnership work. It was, of course, rapid response, and of course, the incredible scientific technical work, but I was proud to see that. Now, there's more work I even want to see as we go forward, but I think it was a really good opportunity to showcase that. Some highlights you probably know, I was really proud of the team for standing up in record time the Bridge Access program that allowed for free access to COVID vaccines across the country with, again, partners. And that's going to be a theme as we get to this working group we'll talk about. They stood that up quickly with our pharmacy partners. I'm really proud of the data work that is happening to align data across diseases, so be disease agnostic. And I hope you have all seen particularly the new wastewater visualizations and how those new tools are informing our work. Now Brennan is here, who's our chief data advisor. Thank you. And that team did an incredibly fast and remarkable job. And I think, again, demonstrates where CDC wants to go, which is putting great information in the hands of people so that they can protect themselves and make good decisions for themselves and their family. And I was also really heartened to see some great engagement with our provider community. That is what we really focused on this fall and winter in terms of communication, because we had 2 new vaccines that we had to talk about with folks. Well, maybe even more. So we had the RSV vaccine for adults. We had the RSV vaccine for pregnant moms. We had the RSV immunization for babies. Of course, we had an updated COVID vaccine. So just a lot new for folks, in addition to reminding folks to get their annual flu shot. And so we really put a lot of effort into communicating with the provider community, and that was just a foundation for what I hope to see. I think I'm foreshadowing again where we're going with the communication and engagement group, because I do think there is more to do. The other part I wanted to bring up was I just got back from an international trip and wanted to just share a bit about what I saw there. One, I went to open our regional office in Tokyo, which I think is a strategically important place for us to be building diplomatic alliances, making sure we're having visibility in that part of the world. So it was a really good opportunity to continue to build partnership with the Japanese Ministry of Health and with folks in that region. And then we got a chance to go to Cambodia. And that was where I got to see the true way in which our investment in global health is protecting Americans every single day. And so the reason we had chosen to go to Cambodia, you may know, after 14 years of not seeing any avian influenza cases, they have now had more than a couple. We're even looking into a few more. They've had at least 4, maybe another one of avian influenza cases from birds. Luckily, we're not seeing any human to human transmission, but it was an opportunity for me to see firsthand the entire way in which CDC and that 22-year investment we have made in Cambodia is right now playing out to protect Americans and prevent avian flu from coming to, getting around that region and then coming to the United States. So we were able to go to a bird market where we're doing active surveillance. They were swabbing ducks, right? They were swabbing those ducks, and then they would run genomic sequencing on that. We then went to the hospital where we talked to the 2 doctors who treated the most recent avian flu cases. We went to the lab where they were able to run those specimens in 7 hours and get a result. Really an incredible turnaround. And then meet with some of the graduates of our EPI training program who went out to the communities, are building trust, looking for cases, asking folks about their symptoms, swabbing folks, right? Doing the just blocking and tackling of great public health on the ground. And what was so important was it was fundamentally built on trust because we are training folks who come from those villages. It was wonderful to see. And I just wanted to bring that back to the committee because we have to continue to remember about the importance of that investment and how, right, that work, that trust building, that investment is what is keeping our world safe right now. So it was really exciting to see. And if anything, we need to do more. And I was so pleased to see the ambassador of Cambodia continue to articulate how important the CDC work was in broader diplomacy efforts in the region, not just the health security work that folks are doing. So really just wonderful, wonderful things. So just to also highlight for the committee a few pieces of additional dollars that we were able to put out in the last year. Obviously, we understand coming out of a pandemic where all the attention, all the funding went to the COVID response, it's going to be natural that we're going to have to go back to quote unquote normal. And we're trying to figure out what our new normal is. But even in the face of that, we were able to make new investments. So we put out $260 million to support the National Network for Outbreak Response and Disease Modeling. So a new investment. We were able to put $390 million into advanced molecular detection and the national wastewater surveillance. Again, things thinking about how are we really getting to that important capacity building, that infrastructure that has to be there to keep us safe. Another $245 million in data modernization efforts, almost exclusively out to our state and local partners. So that was incredible. And then reminding folks that, yes, our respiratory virus response is certainly top of mind, but remember, and I'm going to talk about 2024 as we broaden everyone's thinking about what CDC is doing to protect health. We put out $279 million in opioid to action data dollars. So this helps all of the states do more in terms of tracking and understanding our opioid use, overdoses. And again, you can't solve problems you don't see. And CDC in its role to play there is doing a terrific job of bringing data, evidence, and best practices. And then on the partnership side, we've done, as I mentioned, on the respiratory side, a lot of partnership going on there. But to highlight for you, we released an action guide to promote mental health and well-being in schools. Right. Again, another partnership where we heard from our education partners and we're seeing in our own data about strains on youth mental health, and was grateful to see the team spring into action, really get something practical. Again, how do we turn data into action that people can use? So I was really proud of that. And you're going to hear in our 2024 priorities about how do we lean into that even more. And as we look internally to CDC, again, I'm proud of where we've been. And, the moving forward work was a lot of work, and that continues. But we've completed 75% of those actions that we've committed to, and we are now moving into the next phase of it. So let me move into talking about our 2024 priorities, and then I'd love to open to questions. So I look out. We planned together as a leadership team, and we looked out to this year. Clearly, we want to look at this year, but really, what are we building towards, right? In terms of the CDC's unique role of protecting health and improving lives, right? If that's the big vision of getting to an effective, efficient CDC that is protecting health and improving lives, and making sure that we are showcasing our readiness work, our expertise, and our investments in communities around the country. And so 2024 is really about how do we make sure that we're focusing on some key areas that deliver on that promise. So the first priority for us is really around readiness and response to health threats, and making sure that we are investing in that critical infrastructure or that core capability that allows us to respond no matter the threat. Because the next threat could be a respiratory virus, or it could be an environmental threat. And we need to be ready for whatever that is. And our platforms need to be extensible to that. So do we have the lab capability and quality? Do we have the data infrastructure that we need to detect and respond? Do we have the response capability? And those are the unsexy things of contracts and right, the trained workforce and the right ongoing ready to deploy. And importantly, then we need the people, right, that are talented and can do this work. So we are making sure that is really our top priority here. We have to prioritize, right? So it starts with, well, what are the top risks and threats that we need to think about most? Are we building platforms towards that? So that is a real whole of agency response. Again, disease agnostic to really try to build towards being the best CDC that can protect health and improve lives. Then the other three to go through is, where I'd say in the readiness and response, CDC is the quarterback, right? We are the lead for that across the US government in terms of that response effort to health threats. Two of these other priorities, we're team members, but key team members that drive work. And the second priority is improving mental health. And this is where our data, our expertise on best practices can help drive improvements and reduce suicides, reduce overdoses, and make sure that we are partnering with folks across US government, like folks at SAMHSA and HRSA and CMS, and then our state partners and of course the medical community. So I know you're going to hear a lot more about that from Allison today. We're excited that she's joined the team, and from Dr. Howery. So I'm not going to go into as much detail there, but I'm excited about that work. But it also shows how CDC can, like I said, be that great team partner to drive the work. What should SAMHSA invest in? Let our data guide and our best practices guide how they should invest. Next priority area is supporting young families. And again, that is where CDC needs to be a critical team member here as we work with others in supporting young families. And that is where I really feel our prevention work shines, right? If you think about wanting to get upstream as early as possible to prevent things, right? That is about mom having a healthy pregnancy. That is about those first few years of brain development. It is make sure that our kids get their vaccines when they need to, that they're not food insecure, right? That early, but it's also thinking about our caregivers, right? The parents. I think when folks hear young families, they assume that our work is only child focused, but it is truly full family focused. And how do we think about our caregivers who are also going through their own health challenges, and how do we think about that? So doing a ton of work, maternal mortality, and I know you heard at the last meeting about some of this maternal mortality, making sure our kiddos remain getting their routine vaccines. And I do want to say out loud, 94% vaccine rate. Of course, we'd love that to be more like 96, but we need to remind folks that kids are still getting vaccinated. It's still incredibly important. So we're going to make sure we're doing that. But then, as I said, to also focus on those family caregivers and focus on things like the diabetes prevention program and others. And then the last areas of focus is really internally, right? We can't do that work well. We can't respond. We can't be a good teammate to SAMHSA unless we are the most effective that we are here at CDC. And again, that for us means the next chapter of moving forward. We're calling it, or I'm calling it, One CDC. I want to see this agency operate as one team. That means we have to do some critical things to make sure we have a world-class, diverse workforce. That means training, that means recruiting. Dr. Gale, I'm happy that you're here. It means continued partnership with our historically Black colleges and others as we do that work. But it's also about equity, accountability, and communication in the work that we're doing. I think modernized communication internally is just as important as the modernized communication that we're working towards externally. How do we work together as one team? It means we have to have great collaboration and communication internally. So I'm excited about that the investments that we are making internally there as well. And it's going to help us excel in our data, in our lab, in our workforce, right? So if we are focused on what we're doing internally. From a communications standpoint, I hope you see a big change in our web presence, again, which is a lot of the way the external world interacts with us. We are very close to launching what's called Clean Slate. This is where we're archiving a ton of information that is not readily accessed, and we are making more prominent the things that are really actionable for folks. So I'm excited about that. Gives us the opportunity to really reintroduce ourselves, if you will, and that's what a lot of my time is going to be spent on, is reintroducing CDC to the public. How is CDC working for you in your backyard right now? How are we making meaningful impact in protecting your family's health? Because there's a lot of ways in which we are. I think folks got to know us through COVID, for better or for worse. And now I want them to see how we're thinking about their kids and their mental health, or thinking about them as caregivers and their health, or protecting them from the 2023 being the hottest year on record. How are we thinking about the interactions of heat and health? So we're excited about all of that working forward. And it's not surprising that, Dr. Howery and I have asked you all to think about a new working group that focused on partnerships, engagement, and communication. It is so foundational, but I think we have to be experts, honestly, in partnering. I know we are experts in the science and data, but we have to be experts in partnering, and we have to be experts in communication. So there is work to do there. We have to be able to reach the public in a trusted way with important key messages where we can have people change their behaviors. That is hard. Behavior change with words is tough. So we have to be the best at it. And so prioritizing our communications, thinking about how we strategically partner and do that better, both at the community level and with big national partners that can bring scale to our efforts. Those are the things I think we are looking for advice and help on. How do we both best structure that internally to support that work? What does that look like when we're doing it really well? So I'm excited to hear how you sort of step through that, and I know you're going to hear more about that work group later, but looking forward to it. Okay, I know I talked a lot, but I'm proud of the work, and now I'll turn it over for you all for some dialogue.
Thanks so much, Dr. Cohen. It's really great to see how you stepped into this, and you don't talk a lot. You talk the right amount.
Okay, the right amount.
Yes. I do want to open it up now for not only questions, but comments, suggestions that the committee might have for Dr. Cohen. Let's go ahead on the slides and remove the slide that says director's update and discussion, so that we can actually see the committee members on the full screen. And go ahead and open it up now to committee members for, as I say, not only questions, but comments and suggestions on Dr. Cohen's presentation or ideas that we have for her as well.
Hi, there we go. Now we can see you all.
Dr. Cohen, thank you for sharing your comments, and especially your 2024 strategy. I love the fact that you're concentrating on mental health. And you bring up, brings me to think of one area that obviously you've thought about as well, is suicide rates in the United States are just really a critical component. One of those is, the access to dangerous weapons. Mostly it's guns, unfortunately, in the United States. And I'm just wondering what may be the strategy, given how politically charged it is, to be able to, as you laid into later, how communications and partnership really are so important. How can we turn this around, in your opinion, to be able to know that? Because, suicide often is impulsive, as we know. Half of almost all suicides in the US are secondary to the use of guns. And it is just an area that I think we could really make a huge impact and save so many lives, considering that afterwards, we also know in the behavioral health field that folks that do survive a suicide attempt often can lead still very fruitful lives. So, I mean, it's such a critical moment in time. So I'll stop there just to see what your comments are and thoughts.
Well, first, I don't know if folks saw in New York Times this morning, actually highlighted this issue, and I thought laid it out in a really compelling and easy to understand way about why actually taking away a method of committing suicide, it doesn't mean that they find another, which is so important for folks to understand. It's a paradigm shift. And so, and frankly, thank you, CDC. Like that is what our data has been saying and showing. And as much as, guns can be, more challenging of an issue to work on, I actually hear a lot of consensus when it comes to focusing on suicide and gun safety. And so I think you're going to see us lean in as we work on suicide in that phase. We have to your point, half the suicides are guns. For men, it's even higher. And so we have to address it, and it'll look at like gun safety. I think there are a number of places where we're already supporting some research on best practices related to actually. One is it's almost anticipatory guidance for adults, right? Is do doctors talk about this with their patients? Do you have a gun at home? Is it in a safe place? We were talking about using red flag laws and how and studying them and understanding where they are implemented in different ways. What are the best practices there? So I think there are a lot of ways in which we can, again, bring data and best practices. That is where CDC shines, and where we'll put our focus. So thanks for that.
Early in my career, I did some work in Oregon with adolescent suicides and found that the single, by far and away strongest predictor of whether a suicide attempt was successful was the method, with the guns overwhelmingly being the predictor of successful suicide. So it's really gratifying to hear what you're saying. And I do agree that does seem to be an issue around which there is some consensus that is possible. Josh.
Thank you. And I'm sorry I can't be there in person, but it's great to see you all via the computer here. Just on this last point, I would just say that I've worked with the team that works on the red flag laws at Johns Hopkins, extreme risk protection orders, to do grand rounds in a number of different clinical environments. And there's such an interest from clinicians because it's so scary to them when they see people at risk, and particularly kids at risk. And so in some states, physicians are able to file extreme risk protection orders, and there's a growing set of best practices. There's surveys about that. And I do think it's a really interesting opportunity to leverage the clinical community for a public health goal. I'd actually raised my hand about something slightly different, which is first just to thank Dr. Cohen for the strategic focus she's bringing to CDC, as well as all of the work you're doing. I have my Google alert set for you, Dr. Cohen, and it's crashing my email. You're doing a lot of things. So it's both, strategy, which is really important, and you're sort of modeling the energy that the Centers for Disease Control and Prevention really need. So it's really great to see. I have a question as you're thinking about kind of the big picture about process for the CDC, and whether you've thought about the way CDC makes decisions on difficult topics, and whether there's opportunities for improvement there. I noticed that you've been, or the agency has been kind of stuck in the swirl of competing news stories about the COVID guidance that may or may not be coming out. And I'm not asking about the COVID guidance per se, but it's sort of a classic situation where everyone's angry about a statement from CDC that hasn't been made yet. And it's like rampant speculation, stories hitting you from different perspectives. And I just, wonder whether this might be or an opportunity to think about how these things happen and come about, and how you're thinking about that. Thank you very much.
Thanks, Josh. A hard question. Let me put COVID to the side, because I do think we are working hard on how we change decision-making processes within CDC, and it starts with actually us working differently as a team. And so even just yesterday in our senior leadership conversation, we were talking about how do we think about the alignment of strategy across CDC as opposed to each center coming up with their own, which is good work, but it's siloed and it keeps us siloed. So if you don't start by asking the questions as a team at the senior leadership level and start planning together about how do we invest in data, how do we invest in our lab infrastructure, how do we think about training our workforce in an aligned way, what are the priorities we're going to set? So and so that we have a bunch of new processes around our policy development. Again, I think, Josh, we also have a new deputy, and Andy's going to be here later, right, for just this work, is like to mature that process. And I think you're seeing it. So with different guidances that we have done in the last 6 months, we've put those out for comment, for folks to give us feedback. I think we're doing a much different level of engagement as we're doing that, even internally, right? We didn't have that. But to go to COVID, I think that is just the most sensitive and obviously we're not ready to share things, and the fact that it was out there didn't have again, those kinds of things. Now you don't have context, we don't know what we're really doing, right? So it was disappointing that happens, and we want to have an inclusive and collaborative process, but we also need to have the time and space to do that work. And so it's a hard balance, particularly when it comes to COVID. So I think we are trying to mature a process overall. I think COVID continues to be particularly challenging, and I don't think it's going to set the bar for everything and how we're going to do, just because of the nature of what it is. But we are moving in that direction of different decision-making processes internally, as well as how we get collaborative feedback from folks. And so other kinds of guidances, like what we're doing now for our STI, HICPAC guidance, or I was thinking about the DoxyPEP guidance was up for comment, right? So you are seeing that we're moving that direction. COVID, unfortunately, continues to occupy special space. It's a special snowflake. So don't intuit that the way we do that process is necessarily the way I think we should do it for all. But we're going to do as best we possibly can.
Yeah, it is interesting to hear how your perspective on how unique COVID is. And I suspect many of us were immediately contacted by multiple folks in the media the instant that story came out. It's quite amazing.
My mom beat you all. She was the first
Oh,
to
that's
text me.
perfect.
She's like, what's happening? It's like, oh, Mom.
There you go. So we'll go Julie, Monica, then Helene.
So Dr. Cohen, I just want to thank you for joining us last evening. It was a pleasure having you there and appreciated your comments. And then also want to appreciate and maybe double down on what Josh was saying in terms of the strategic approach that you're taking to the work. In 8 months, you've got a plan. And what I loved specifically about how you describe the work is where you've identified that you're the CDC is a quarterback in some situations, but you actually are a partner in others. Because I think that helps really to optimize the resources and capabilities and recognizes the role that you'll play in the work that you're planning. So I think it's really smart and appreciate the work that you put into this so far. The other thing I was going to say that is more of a question in terms of marginalized communities. We think about the impact that COVID had on disproportionate impact it had on our marginalized communities. And as you outline the other priorities for you, I'm just wondering how those marginalized communities are considered in your planning. Because I think many are backing away from equity, the use of the word, the use of diversity, the use of the word inclusion, but yet we know that our marginalized communities really are more severely impacted in almost every disease. And so I'm just curious how you're thinking about approaching that work.
Thanks for that question. I think I think equity work has to both be called out separately and embedded in everything that you do. So yes, of course, we have a health equity office, and of course, we have our ways of thinking both about our programmatic equity work and our internal CDC diversity, equity, inclusion work, which I call belonging. When I talk about it from a values perspective, that everyone here belongs, but it has to be owned by everyone. And so it can't be the health equity team owns that for CDC, and then we're done. And I do, being newer to CDC, I want to commend the organization CDC. It is the most equity focused organization that I have had the privilege of being part of. It is great. That is a wonderful foundation. I think it is not something that needs to come top down. I see it everywhere that I look now. But I think the place that we need to continue to do better is on the understanding the realities of the community. And I think this is where that work group is really critical. I think that while it is not just enough to say, ask the questions and think about interventions, but what I think about equity work, and maybe this is, again, I'm more of an operational person. Good operations is equity work, right? And what I mean by that is we think about vaccine access, right? As you were saying, is a piece of this. Not just collecting good race and ethnicity data, right? It's thinking through in a systematic way, what are every way in which our program touches different communities and how those access point works from how do we manufacture, how do we ship, where are those access points, what's the price point, who's talking about it, everything, right? All of that is good execution and equity work. And so for me, because I'm more operational, you're going to see my focus on equity work be in operations. I think the communication is important and the messaging, obviously, and the trusted builder, but also I want to see that get more reflected in our operational work. Like I said, CDC doing terrific work already in the equity space. My focus is for this year is getting that into the operations.
Yeah, I really appreciate that. I mean, you referenced it when you talked about Cambodia and how important it was to really be on the ground and to be working with people from the communities to really get the work done. And it's coming through in the way you're describing what you're prioritizing through the work ahead. So I appreciate that. Thank you.
One of the people I most respect in Seattle, who was eloquent on talking about equity and health equity, says, many people think about equity as being an outcome, but equity is actually a verb. It's how you get there. And so it's been good for me to think about. Monica.
Thank you. And thank you, Dr. Cohen, for providing us with updates on the evolution of the work on your strategic priorities. I appreciate also hearing about the One CDC approach. And I think I hear this in your response to Julie's question about impacted populations. And so another thing that I heard, which was different, that we're excited to hear more about, and I'm particularly interested in how you're approaching the work, is heat, the interactions of heat and health. And just picking up on what you just lifted up in terms of operationalizing equity and seeing equity in action. I think a great example of how, for me, as someone outside or external to CDC, is seeing this show up is in the use and the development of your environmental justice index. So I heard you describe the work as interactions of heat and health, but I was curious if you could say more about how you may be considering the work in terms of the intersection of climate change, health, and equity.
Well, thank you for that, Monica. I think we are putting a focus on the intersection between health and heat this year. And again, focusing on what is it that CDC does best, right? Go back to the fundamentals, like we bring data, expertise, best practices to bear. And so what we're focusing on first and foremost is making sure we have good data for folks to then build upon to make good decisions. And so we're working towards ways for everyone to be able to see a heat index. As I was learning even just yesterday, 94 degrees in Miami is not the same thing as 94 degrees in Burlington, Vermont, right? And so we need to understand how different temperatures impact folks. And understanding that our environment is changing and thus the pathogens are reacting to that, whether it's vectors, right? Our mosquitoes are changing, our ticks are changing, but also what are the pathogens that are getting defrosted up in the North Pole and that the world is going to see. So we're staying on top of the infectious disease component of the heat is important. So we have some just fun foundational blocking and tackling to do, as I said, on getting the data right, getting our detection surveillance work in the right place this year, to then build upon that on, well, so what? Like, what are the most important things we need to do? So I think we're still in, if it's crawl, walk, run, we're still in crawl. So I just want to say that out loud because we have some work to do, but we're excited about about the potential here, because I think we have to go there in order to fulfill our mission to protect health and improve lives. Like with 2023 being the hottest year on record, we have to do more in this space because the world is changing. Hear you on the environmental justice aspect of that as we do and build this work forward. Thank you.
Thanks. We'll go to Helene and then Joe.
So, like everybody, I really applaud the priorities, and I think coming out of a time where people stopped understanding CDC's mission and role, to have that kind of clarity, I think is great. But I think it also poses potentially a couple of questions, a couple of issues. So as you talk about one CDC, it is always hard in any organization to say you're prioritizing and to not have other parts of the organization think that you have forgotten them. And so a challenge to your concept of one CDC. So anything you want to say about that and how you're trying to take the organization through that? I think the other thing is that, and it's come out in some of the comments that people have made, some things get lost that are also still important. So the fact that equity is not necessarily strongly stated up front, I think it will be important to make sure people understand. And I think your description of operational way of thinking about that makes sense. It won't make sense to a lot of people because it sounds like it's still getting demoted. So I think there will be things like that, thinking about how you nuance that and make sure that people realize they are still prioritizations. On the mental health, it's another one where I think it's a great framing of thinking about it in the terms of suicide, overdose, and issues that people all agree on. But there's another issue that people don't all agree on that will rear its head regardless, and that's homicide and I think, and gun control. And no matter how hard you try to keep it in boxes that people feel more comfortable with, I think being prepared for the fact that there will both be people who feel you're turning your back on a really large issue and others who will pull you into it even if you're trying to. So I just think, kind of thinking about that and how you want to position that and communities that are impacted by that, making sure people feel like you haven't, forgotten that, but still don't get yourself broiled and whatever. So good luck on that dance. And then I guess the other was just a question. You mentioned mental health in schools, and because I'm in a institution of higher learning where it is such a huge issue, I'm just curious how you're thinking about schools, what level, areas of potential partnership, et cetera.
Let me take some of those off. So on the how can, we thought hard as a leadership team to make sure our priorities felt elastic enough, that was a word we were using yesterday, elastic enough that everyone can see themselves in that, particularly as we think about one CDC with a world-class workforce that is diverse, that is focused on equity, that is accountable, that is communicating well. That is every single person at CDC, no matter where they sit, whether they're in HR, or they are doing security out front and protecting us, or they, or they're doing programmatic work. And so, from a, I think our mission to protect health is very aligned with the being ready to respond. And then there are two areas, of focus, and not everyone is going to see themselves in mental health, and that's okay. But we're hoping that we had these buckets that were elastic enough that everyone can see where they fit in. And in fact, my charge to our leadership team was to talk about this with your team and help them understand how they fit in. Thank you. Good feedback on making sure equity is more strongly stated here. And I don't want folks to think because it isn't in the 1, 2, 3, 4 of priorities that it's not. But I said you have to both call it out specifically and bake it in everywhere. And I'll take that feedback on how can we get even stronger. Thanks for the feedback on the violence and homicide and how do we get to that work. My experience in North Carolina and doing work in a place where I worked for a Democratic governor and had a super majority of Republicans, with the way we found our way forward in working together was to first align on some things that we found consensus on. It didn't mean we didn't care about other hard issues, but start where the place we have consensus, build trust and put some wins on the board so we can show that we can work together. And then we take the next step and the next step. So that is a bit of how I'm thinking about, at least through my tenure here, as I try to navigate making sure that CDC can have the resources it needs to continue on that work. So we are articulating priorities where I see more consensus, but it doesn't mean that there isn't other things that we want to do in the future. But I'm hoping these allow us to build a foundation of showing that we can work on hard things together and then we'll go forward from there. And then I didn't want to, on the mental health piece for schools, I know Dr. Howery is going to do a whole presentation on that. So I'll let her get to that one.
Hi. So thank you for all the work that CDC has done on labs. You've made a great deal of progress. There are things that still need to be done, and what we're trying to advocate at the moment is that you get the money to do what needs to be done. So
Thank you.
I'm a virologist. I am worried about measles. There is measles all over the world at the moment. And the one that really scares me after that is polio. And if our vaccine rates keep going down, don't people remember about polio? It just frightens the hell out of me. Okay, so that leads me to the point of a very sensitive issue of vaccine mandates. And I really, it's such a difficult subject in this world at the moment. But I don't think it's one that CDC can avoid. I've said it before, Americans don't like being told what to do. So how can we figure out a way to pros and cons in a way that's not in your face and confrontational, and aiming at doing better, not being perfect even, because any progress we can make in increasing the vaccine rate is worth doing. So I just, maybe it can be a subject for the communication work group, but I think it needs to be a broader conversation about how we can do better as a country. Thank you.
Great feedback. And certainly we, on measles front, obviously we are tracking all of that closely, and not surprising, like the cases that we see are folks who are not vaccinated. But we know that we need to keep doing work better. And on polio, I think that CDC continues to be strong partners in the polio eradication work. We have a lot more work to do, even with the global investment that is being made there. And the reality is folks have forgotten. And it's sad that we have short memories, that these things are so serious. So I think that is a great opportunity for this work group on communication. How do we continue to help have folks understand those messages in the context of not seeing cases? So it's hard for folks to understand.
It's always a delight to have you here, and I'm always impressed at how wide-ranging the questions are. So it's sometimes tough to get coherence across the questions, but you're doing a wonderful job at that. I did want to ask, again, to change the subject a little bit, appreciate the notion of one CDC. It's something that CDC, I think, has recognized and struggled with in the past, in part because of the categorical nature of the funding that comes to the agency, which creates natural silos. I also know that you're an ex-director of the health department at the state level. And so you know that the same dynamic plays out at the state and local level, where health departments tend to be an amalgamation of individual programs rather than a unified organization, in part because of that's just the way people are, in part because that's the way that the funding comes.
Yep.
And I'm wondering if there's any thinking that you are doing or that could be done at CDC to recognize that one of the barriers at the state and local level is the categorical nature of funding and the difficulty in using those funds across a state and local health department to make the right things happen as a one state health department, one local health department. Is that something that you all can think about or perhaps think about making improvements in?
Yeah. Well, thanks, David, for that topic. And it's something I think about often as someone who came from North Carolina. And, I was Secretary of Health and Human Services. So I had the opportunity to bring together public health and Medicaid and our mental health dollars and early childhood dollars. And what was great about having all of those under one roof is the idea that we planned together so that we were able to braid funding in a different way. But I know that that is not the reality of every state. Plus, you need leaders who are willing to sit at the table and braid funding, which requires a huge level of trust between people who work together. And that didn't happen overnight in North Carolina. It took us a while to get there because, it is hard to when you're given a certain amount of money, you're like, that's mine. There's a lot of that at the state level. And so it's challenging, but very doable. And I think though, for 2024, we have very much focused internally at CDC. How do we do that better, right? If we want to see that at the state level, I think we need to role model that at CDC first and foremost. And, look, our budget structure is not going to be something that changes overnight. So we are trying to figure out the ways in which we can come together as a leadership team and do that within the constructs of what are. So here's an example. And again, we were talking about yesterday was even in our data investments. That is a critical infrastructure or a core capability that we need to have. Every program needs it, but we have 300, 600 plus systems because every individual silo built their own. And not that one is bad and one is good. There are probably ones that are better and not, but we have to right size that. That's both for effectiveness, efficiency for our budget, but it's hard because that means change and the investment of dollars in a different way. So we're going to try to work through that as a team the best we can. And then we have to start having conversations with our congressional partners and our appropriators about, and we already have, about investments in these critical infrastructure or core capabilities, data, lab, workforce, response capabilities in our global work. Those 5 are what I talk about with Congress already that are disease agnostic. They're platforms, right? That can be extensible no matter what the threat is. And it doesn't mean I'm taking my off the ball of TB or avian flu or HIV. It means those things can go further if you have a strong platform that is interoperable, that is extensible, right? So, but we have work to do. Like that is not an easy gap to jump over. But I think what you will see in our 2024 plan is sort of a down payment in that. And then we need to just, it's one of the things you have to chip away at over time.
Well, we look forward to working with you on that. I know that our data and surveillance work group is helping you to grapple with that issue, particularly with respect to the number of data systems that are out there. And we're just, as you've said, we'll just add, I think that some of the issues around health equity and equity also provide a unifying focus across different programs where co-investment in resources would make a huge difference as well. Any other questions, comments, suggestions from the committee? Not opportunity for last words, but thank you very much on behalf of the committee for being here. It's always heartening to hear you speak and to hear the progress that CDC is making and how quickly you've assumed the role of being the leader of the agency.
Thank you. And I have really appreciated, I read every one of the reports and to make sure that we were taking the smart advice that we were getting from these work groups. So I'm excited about the launch of this new one as well to help further our work. So I know everyone is so busy. I'm just so appreciative. Thank you. Thank you for your time that you invest in this. Okay. Thanks, everyone.
Great. Deep breath. And we're going to move on because I see that Les is here. We're going to now move to a discussion on public health accreditation. Dr. Dauphin is the director of the National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce, which I learned last night is now being fondly called the Infrastructure Center, which I was always wondering what the acronym for that new center was going to be. Dr. Dauphin, you have the floor, and we look forward to your presentation.
Thank you. Good morning, Dr. Fleming. Good morning, everyone. It's such a pleasure to speak with the ACD. It's been over a year since I spoke with you last, and sorry I could not be there in person. So we were thrilled when Dr. Cohen identified public health accreditation as a topic for the ACD. As many of you are aware, CDC plays a major role in supporting public health departments through either direct funding, support of partnerships, and by providing tools and technical assistance. The National Voluntary Accreditation Program is managed in CDC's Public Health Infrastructure Center and our Division of Partnership Support. And I do just want to give a quick sort of shout out and welcome to Liza Corso, who I believe is in the room, who has really been leading this work for many years and is recognized as an expert in this area. So today I will briefly provide an overview of the program, CDC's investments to support this program, the current state of accreditation, sort of by the numbers, and then share some evaluation findings. We've also posed some questions for discussion. So next slide, please. Thank you. So accreditation of health departments is really about standards and measures that are intended to raise performance and reflect current public health practice. These standards and measures are organized into 10 domains, and they're aligned with the 10 essential public health services, which is really a framework that promotes policies, systems, and services to enable good health. I should mention that this, the latest version was revealed in 2020 as a part of the Futures Initiatives, the 10 Essential Public Health Services, the Beaumont Foundation, the Public Health Accreditation Board's Center for Innovation, and a task force of public health experts really put out this new framework in 2020. What you'll see, if you can see that diagram, is that the new framework has health equity considerations. They're included in every domain. The foundational capabilities are also embedded. And these standards include some major activities that health departments should give attention to while they're working on improving the services that they provide to their committees. So briefly about the program, the accreditation process is about meeting standards. Health departments are required to use either documentation or a peer review process, and it also involves site visits. Once accreditation is achieved, it is for a period of 5 years, at which point the health department can seek reaccreditation. And the reaccreditation process is a bit more streamlined with fewer standards and measures. while also assessing that the health department has continued to make progress. So it's about continual quality improvement. So now about the program. Let's go to the next slide. It is a voluntary program, and the Public Health Accreditation Board serves as the accrediting body. Following some recommendations in 2003's Institute of Medicine report, CDC and the Robert Wood Johnson Foundation played key roles in sparking sort of an exploratory process into looking at what accreditation should look like. So as a result, if you look at the bottom, you can see that the National Voluntary Program was established in 2007, and the board was established in 2007, and then the program was launched in 2011. The first health departments were accredited in 2013, and as I mentioned earlier, the accreditation period is for 5 years, so the first health departments were reaccredited in 2018. To date, CDC has been really making investments and supporting this. We have funding the program through cooperative agreements and providing support, and really trying to support health departments in achieving accreditation. Let's go to the next slide. A little overview of investments to support accreditation. So since about 2005, CDC has consistently invested in accreditation activities. This slide illustrates the amount of funding provided to the Public Health Accreditation Board, or FAB, through successive cooperative agreements. So if you look at the bottom, the first cooperative agreement, HM 08-805, was funding to national partners, of which FAB was one, to address public health infrastructure and core activities, including accreditation and performance standard. Since that time, CDC has invested in successive sole source cooperative agreements to the Public Health Accreditation Board. So you can see that since 2013, there have been 3 different sole source cooperative agreements to FAB. That's OT13, OT18, and now the latest 2023 cooperative agreement with funding roughly between $800,000 and $1 million. One thing I should highlight is that this chart does not show the co-funding and support by the Robert Wood Johnson Foundation. Through collaboration with CDC, RWJF implemented some complementary strategies that contributed to national accreditation success. For example, CDC worked on supporting the use of these national standards, while RWJF supported the development of new quality improvement tools. Okay, let's go to the next slide. Would like to provide an overview. So what is the state of accreditation of health departments today by the numbers? You can see as I move from left to right that almost all state health departments are accredited. And the way that we look at this is in terms of the population served by the health departments. So 80% of the 51, which is the denominator of state health departments, are accredited today. And then of the more than 2,000 local health departments, 389, which is approximately 17%, are accredited. And there are more than 80 who are currently pursuing accreditation. With regard to tribal health departments, 6 health departments are currently accredited by FAB, and there's several more who are in process. I should highlight that also FAB has contracted work with DOD to accredit all Army installation departments of public health. So this has extended beyond just state, local, and tribal public health departments. There's also one international ministry of health that is accredited, the Qatar Ministry of Public Health. Overall, there are about 111 health departments that are either engaging in or eligible for reaccreditation. Just a little bit about the pace of accreditation recently. From 2020 to 2023, there have been 5 state, 61 local, and 2 tribal health departments that have achieved accreditation status. The pace of states has slowed a bit, But we're at a point now where there are fewer state health departments now accredited than not accredited than accredited. And the pace of local health departments between 20 and 2022 was pretty steady, with about an average of 24 local health departments per year. But that number has decreased a bit to about 10 per year. It's important to sort of provide some context here that FAB granted extension of accreditation activities to health departments in response to the COVID-19 pandemic. Extensions were common in the past few years and may now account for some of the changes in paces that we've observed, particularly at the local health department. All right, let's go to the next slide. Just for an overview of what we're learning about accreditation. Since 2013, NORC at the University of Chicago has conducted surveys of health departments when they reach important milestones. And so this is typically 1 year after accreditation or post-accreditation, 4 years following accreditation, and through the reaccreditation process. And the purpose here is to really collect data from health departments to learn about the process, to inform process improvement, and to sort of document outcomes to inform decisions about the future state of the program. So the respondents are health departments that register for accreditation and those that are accredited. And the results are self-reported, and they have an opportunity to share their successes as well as opportunities for improvement. So if we look at this data, I'll just run through a few of what we see here. You can see that 95% who reported in a post-accreditation survey, and the denominator here is 281, indicated that they saw improvements in quality and performance. Again, this is self-reported data from health departments who achieved accreditation at 1 year post-accreditation. Similarly, 88% indicated accountability and transparency. This is from the same set of data. Post-accreditation, 1 year, denominator 291. We can also see that some have reported relationships with new partners have been helpful. This is from a survey that was conducted at year 4 of accreditation, and the respondents were 204 who participated in that. Now, with regard to reaccreditation, some have reported 31%, if you look at the bottom corner, a decreased perceived value or benefit as a challenge for reaccreditation. And this is from a survey of 77 participants between 2020 and 2022. So there's several items that we're sort of paying attention to. Challenges that we've heard regarding reaccreditation have been related to either staff time or staff turnover, changes in leadership. And importantly, we've heard as we've engaged at the state and local levels that there are some burden perceived, particularly with regard to the cost and the amount of time and effort to achieve accreditation. Let's go to the next slide. So I want to pause there because I'd like to entertain some questions that we've posed here, and particularly around CDC's role and how we can work better to assess if and how accreditation has helped public health agencies improve the quality of services. And I think that's really the question that Dr. Cohen was really interested in when we talked about this. What kinds of things should CDC consider as we think about the new standards and measures? And what role should CDC offer to public health agencies to help support their efforts? We have worked on incentives, which I'm willing to talk about if there are questions, and also trying to identify opportunities as we work with FAB and other organizations to provide technical support and to really see if this is really achieving its intended outcome. And then finally, how can CDC help build public health agencies in addressing barriers such as those identified in the previous slide? So Dr. Fleming, with that, I will pause and turn it back over to you.
Thanks so much for that presentation on this really critically important topic, Dr. Dauphin. We've raised a number of questions here. I'm going to open it up to the committee to provide comments, suggestions, and we'll start with Josh.
Thanks so much, and thanks for the great presentation, Dr. Delphin. I really appreciate it, and I know how much progress you're making at CDC to support state and local public health agencies. I have a general kind of comment and then a specific question. So my general comment is that the pandemic caused a lot of introspection in public health, about, how things are going, about the huge variation in public health structures and responses across the country. There have been many different kinds of after action reports. And I'm wondering whether there has been that kind of introspection about accreditation, because there are a number of places that were trumpeting their accreditation that really, struggled a lot during the pandemic. I don't mean everyone struggled during the pandemic. I mean, they struggled a lot. And some of the after action reports have just been kind of brutal about the health department's ability to do basic things during pandemics, and they were accredited. And I appreciate completely the idea that, there's been a huge focus, for example, on QI, and you see that in the NORC report, and it's really important for public health. I mean, I'm not trying to in any way say that public health accreditation is invaluable, but I just wonder whether there's been introspection on that. And I'll end with a specific point, which is that states are able to get accredited even if a lot of local health departments in the state aren't accredited, and even if there really isn't the foundational kind of coverage of the state. Like, if the accreditation tends to be organized to what the state is doing and can the state do this, not so much what services or coverage that the people in the state can count on, And I just wonder whether that kind of introspection is important. It could manifest itself concretely in CDC looking for changes or soliciting potential changes to accreditation based on the experience of the pandemic. I happen to be a supporter of accreditation. I just wonder whether kind of continuing with the same playbook really makes sense given what we've learned in the pandemic.
Great. Thank you, Josh. And I know we've had discussions about this over the past couple of years. So that was a lot. I'll start with yes, yes, and yes to all three. We have had a lot internally and really thinking about, one, it kind of goes to my first question, how does CDC assess if accreditation is really helping public health agencies improve their quality of services? When we look at the state level, to your point, yes, states can receive accreditation, and local health departments really working at the community levels may not. And they have different types of challenges and burdens, which we've talked about and we know about, and we actually had studies to look at this. One of the things that I will say that is underway that will really kind of look at what you're mentioning, Josh, is we have a few impact studies that are ongoing. So the first, I would say that Public Health Accreditation Board is funded 3 that are planned to really kind of look at what you're asking about. How can we look at the impact of accreditation and really look at helping, particularly at the local level, overcome some of the burdens? There's a second study that's looking at sort of the impact of accreditation in different areas, as Ohio, for example, and you're aware of, is the only state that actually mandates accreditation of their local health departments. So that's another area where we're looking to hopefully get some data that can help inform this. A third is experiences of accreditation among small, local, rural, and tribal, and territorial, and actually freely associated states. We're looking at learning from those and really seeing how to help overcome burden in these areas where we know it's extremely challenging to attain accreditation, and to see if those services are really meeting the needs of those communities. Because to your point, we recognize the diversity among health departments and the services that they're able to provide. So a lot underway to look at that, but it's an ongoing discussion and plenty of work in this area.
Thanks. I'll go to Julie next.
Thanks so much, Dr. Dauphin. I don't know which way to look. Is the camera there? There. I feel like I want to talk to you. But
Can we see you? Oh, we can see you now. Thanks, Julie.
Can you? Okay. So thank you so much for your presentation. So I have a perspective about accreditation because the Robert Wood Johnson Foundation, as you referenced, and thank you for acknowledging our support in the past, but also as one of the first large city local health departments that got accredited. So I've been through the process of accreditation and also reaccreditation. And I'm thinking along the lines of Josh in terms of stepping back to say, like, what is the bigger question? The accreditation is a process for demonstrating that health departments can do certain things or box checking. In some ways, I felt like the process was actually fairly a box checking activity. But I think the real question is, what are the 10 essential public health services or core capabilities that all public health departments should actually have? And it gets into what Dr. Cohn was talking about earlier. It's less about the siloed activities that are happening within the different parts of the organization, but what holistically is a public health, an effective public health department really need to have, and whether or not there's a way for CDC to play a role to support ensuring that those public health departments have the core infrastructure that's necessary for them to be effective. Because I mean, that is the challenge. When in Chicago, we would get our siloed funding based on particular disease processes or particular issues. But what we lacked was core infrastructure funding to support the basics, to be able to step back and say, yes, we are a strong organization that is capable of doing all of these capabilities, and we need to get this work done. And there was a time when CDC did provide that kind of support. So when we were accredited the first time, we had some support for that infrastructure, and it was incredibly valuable. But then the funds went away, and we were again back into our siloed way of working. And so I feel like there's value, and I think it's important to look at accreditation and think, this is really just a process of saying that health departments have what they can do, what they are supposed to be able to do. But really maybe the role isn't about CDC and accreditation as much as what is CDC's role in ensuring that state and locals have that core capacity, because we sure weren't getting it from the state and local funding that we received. And so we were so very reliant on the federal funds that we got. So I just want to challenge you with that.
I really appreciate you raising that. The funding is probably one of the biggest challenges that we've learned about that we face. I did want to mention something since we talk about, what is CDC's role in supporting here? Yes, we agree that there should be standards and measures. And yes, we agree that accreditation is a way to measure whether or not a public health department has achieved those measures or standards. But CDC's role in really helping health departments achieve a level where they can support and protect the health of their communities is really what this is all about. With regard to funding, I should mention, one of the ways in which we can try and would love to continue to support at the state and local level is through that funding that really supports building the public health infrastructure so that they can provide those core capabilities. And right now, the way in which CDC is able to do that, one of the ways is through a very small and new appropriation that really helps state and locals have the funding to do some sort of building their capacity in the areas that they see fit. And that's through the public health infrastructure and capacity line. Outside of that, and supporting at the state level and local level, we really, it's a struggle to really build those foundational capabilities. So we know that what is needed is more sustained funding to help state and locals build their infrastructure and their capacity to serve their communities in the ways that they can do so to meet their needs.
We may have more discussion on this point, but let's go to Daniel and Helene.
Hi, Daniel.
Hi, how are you?
I'm good. Good to see you.
Hi, everybody. So Dr. Dauphin, of course, you always elucidate these very complicated issues, and I appreciate it. I'm curious. I noticed, the focus was on local, state, and a personal passion of mine has been on the U.S. territories. And I just visited the Virgin Islands. I was in Puerto Rico last fall with their health department leaders. I'm curious whether this program allows territorial health departments to join? And if not, what's been a barrier for them not participating? And then the other thing that I also wanted to touch on was the local health departments. I noticed on your slide, you talked about 389 are participating in accreditation, but there's a total of 2,309. So there are far more that have not been included for accreditation purposes. So you listed the 3 top reasons for reaccreditation. I'm curious, for those who haven't sought accreditation, what are their top 3 barriers that they've listed for that? So with the territories, with the accreditation piece for those, I'm just curious your thoughts.
Great, thank you. Let me just start by saying one of the ways in which we're really trying to help territories and freely associated states and others achieve accreditation is through our public health infrastructure grant program. I think I briefed this group about that briefly a while back. This is one of the ways that we're really trying to work with territories. Right now we have one territory that's in progress of trying to achieve accreditation, but they do have unique challenges. It really comes down to capacity. And this is the same that we see at the local level. Having personnel in place that can actually work on this and go through the process of accreditation. The second is around funding. You asked about what are some of the barriers. We know that funding is one of the challenges. Having capacity to focus on this and having the funding. We are trying to do our part in not only supporting FAB, but also through these other mechanisms that I described, for example, the Public Health Infrastructure Grant, to get funding out to help them and encourage and incentivize accreditation. We also, from our Division of Partnership Support, provide some tools and technical assistance. So we're really we are diving deep here. This is a complicated, large and challenging approach, but we really are trying to help those who are having difficulty there where we can. This is why engaging you is really, really helpful. We're interested in your thoughts about things that we can do to support, particularly at the local level and others who are having difficulty or facing unique challenges.
Go ahead, Leilene.
I didn't see it.
Yeah, thanks for a great presentation. 2 questions. One, now that you've gone through one accreditation and a re-accreditation, what are some lessons learned, and are there things that you would consider modifying, evolving in some way that you think could make it more effective? And then the second is, clearly, as everybody has pointed to in one way or the other, the real goal is building the capacity at the state and local level. And one of the biggest barriers is obviously the resources. What are you thinking about in terms of advocacy or other ways in which you can elevate this so that those who could provide funds understand the core importance of this?
Thank you for that question. So to your first point, and I will say the Public Health Accreditation Board, FAB, continues to document and learn from the challenges and successes of those who are achieving accreditation. So we document that. NORC continues to survey so that we can hear from health departments, and all of that's used to inform the process as we move forward, as I mentioned. That will too also help in consideration of the latest version of standards and measures, which I think will be released in 2027. This is really a field-driven process. So we document the lessons learned either through evaluation, direct engagement at the state and local level, and what our partners are learning. Now, in terms of elevating the message so that we can get more support.
Oh, could I just kind of double click on that one? I guess what I was really asking, maybe are there some big lessons that you have learned so far that that would be useful to share? Any specific things that you think you've learned from the evaluation, the ongoing evaluations?
Well, first I would say that some health departments need help. The biggest challenges that we are hearing about are around workforce, and we talk about this as much as we can. I don't think I need to tell this group about the challenges, workforce challenges facing state and local levels. They simply do not have the people that it takes to really implement some of this. So one of the ways in which we are trying to support that is through I'm going to go back to the public health infrastructure grant, which really had some funding to support workforce at the state and local level. That's one of the ways. In terms of advocacy, we try to educate as much as we can, particularly on Capitol Hill, about the need for sustained funding to support our public health workforce. And we also work very, very closely with partners so that they too have a part to play here in educating as much as we can about the need to sustain our public health workforce. Without those boots on the ground folks at the state and local level, we simply cannot move forward any of our work. So we consider this our most precious asset and really where the opportunities are, funding and workforce to support this. And I don't know if that addressed your question, but really
thank you.
that's where the
And-
partnerships are helpful.
And I should have said educate, not advocate. I've been out of government too long.
We educate. Thank you.
Hello, Les. So I want to touch on something that Josh mentioned, and he talked about variability. So I'm speaking from the laboratory's perspective within the health department. And post-pandemic, many laboratories around the country are looking at who they are and what they do. And we at APHL have been doing a lot of work in, it's not a strategic planning process, but it's really is the menu of our testing appropriate for the world we live in now? And in many cases, they've got this sort of, well, we've been doing testing X for 20 years. Should we still be doing it? Or is that something that can be contracted out more inexpensively to a high throughput lab, a commercial lab? And their readiness capability is not good. So I'm just wondering, as part of the accreditation process, is there a step before accreditation of thinking, is what we do supporting our community, and then accrediting based on that rather than who I am now? It's more like, who should I be? And just wondering if that would be a valuable thing to, it's not every health department. I echo what Julie said. I went through the accreditation program process in New York, and to a large extent, it was check the box and questions that really didn't relate to us as a lab in the health department. And so I'm just wondering if there's some rethinking about preparedness for the future before the accreditation process.
Yes, thank you for that question. We could talk separately at length about the laboratory part. I think you know my background in laboratory science and work with APHL over the years. So I think to your point, the accreditation process is and should be about capabilities, right? What are the capabilities that a health department should have, either no matter where they are, local, state, tribal, the freely associated states, to serve their communities? And that's the big question. Do we have the capabilities? Do we have the ability to support and protect the health of our communities? Thinking about how to look at these measures in a way that support a variety of settings is a bit of a challenge. And I would say that one of the things that FAB has done to sort of think about this is they've created this pathways process where a health department may have some difficulty in achieving all of the standards and measures that are outlined through the full accreditation process. So this pathways approach is a more streamlined way to look at, here are the sort of basic capabilities that we should have to support our community. So it's another track to help health departments look at accreditation while they're thinking about capabilities that they may not be able to achieve all of the standards right away. So it's sort of a streamlined approach. That's one of the ways in which this has been addressed.
Thank you.
So we'll go to Rhonda and then Monica.
Hi, I wanted to ask you, you did a great presentation and I got to hear a little bit of a preview of your speech before. I thought you did really, really well. I don't know, do you already work with ASTO and with NATO? Are they providing technical assistance to the local
Absolutely.
state health departments?
So we partner with both ASTO and NATO in a variety of capacities, and one of which is support of state and local providing tools and technical support. I should mention that they are, ASTO is a major funded partner, as is FAB through the Public Health Infrastructure Grant. And we have tried to, through the Public Health Infrastructure Grant, Dr. Meadows, incentivize accreditation and encouraging, can these funds be used to help you achieve accreditation? And if you're not interested, because this is a voluntary program, we're actually planning to meet to find out, why are you not interested? And are there some barriers that are to achieving accreditation and things that we can do to help you? So absolutely, the partnership is a very important piece of this.
Monica.
Thank you. Thank you for sharing these updates about public health accreditation. I too, in a previous life, had been at a large urban health department and had picked up the mantle on accreditation activities. We did get accredited. It was more than a checkbox exercise. And this is all pre-COVID, all hands on deck to keep the emphasis and the focus on preparing for accreditation and then eventually becoming accredited. And I wonder, given some of the data that you shared in the decreasing numbers during the pandemic and after COVID of the numbers of locals in particular that are becoming accredited, whether whether CDC and FAB has thought about, you've emphasized capabilities, and I wonder if there's a connection with incentivizing or encouraging accreditation as a way of gaining credibility and trust among community partners, policymakers, and other partners that the health departments have to work with on a day-to-day basis. Because I think the interest and the recognition that accreditation is important is there, but there's the will and the lack of workforce, as you pointed out too. And so I'm wondering if there's if there have been other ways, and I imagine there have been, explored through FIG and other resources through the different cooperative agreements to tie accreditation back to regaining or building trust and credibility and communicating the great work that our health departments have been doing.
Right, thank you for that. That is actually one of the ways in which we try to educate officials is by highlighting our support of accreditation, because we do recognize that that's something that policymakers and others understand, right? They understand standards, measures, external bodies coming in to say that an entity has achieved some level of standards, and that's been documented by an external entity. So certainly we use every opportunity that we can to talk about this in terms of tying it back to credibility, if you will. I want to go back a bit to something you mentioned, and also a question that came up that I don't think I addressed directly. It's about incentivizing this. You know, outside of the funding that is provided through things like the Public Health Infrastructure Grant and other funding approaches, the cooperative agreements that have been used to fund FAB and our work and our partnership with other organizations, we do try to incentivize, and I think a lot is done also at the state level to incentivize their local health departments trying to achieve accreditation. wherever there is an opportunity to either provide support or additional funding that we can, we will try to do that. The technical assistance is another way in which we try to really, really help. And I should mention there was actually a study that was conducted in 2014. It really looked at, what are the incentives that we're hearing from the field that have been helpful, and what are some of the burdens that health departments are trying to overcome or saw when they were trying to achieve accreditation. Tying it back to credibility is just one of the ways we've tried to sort of talk about this, but this is again where our partners can help. So I hope that addressed your question. I'm touching on a few things here.
Thanks, Les. Octavio.
Dr. Duffy, great presentation, really interesting and obviously extremely hard work. One thing it made me think of though is, and pardon my ignorance, but is interoperability part of this accreditation and or is it a part of the standardization that needs to happen across the US in reference to our public health departments?
That is a great question. Is interoperability a part of the standards? I'm not going to answer that question directly because I'm not sure. I want to make sure that I give you the right answer, but I do think one of our technical experts is there. I'm going to call out one of our staff, Liza Corso. If you are there, can you address that question? I want to make sure that I get this right. So I'm going to call on the expert.
Yeah, Liza's here.
Oh, great. Going to put her on the spot then, Dr. Fleming, if that's all right, because I want to make sure we
Absolutely.
get the right answer for that. Liza?
Thank you. So you're speaking to interoperability and as it relates to data and surveillance systems.
Yeah, exactly.
Yes.
Oh.
To be able to, yeah, exactly, to be able to share the data and for it to roll up and down, throughout the systems to ensure that in fact.
Absolutely.
Yeah,
And there have been increasingly rigorous levels of expectations around data sharing, data use, and what they're showing with systems with the successive versions of the national standards. So that's actually an area that with the different versions since its launch has increased with each time. And with this last version, we worked closely with individuals and experts from both the Data Modernization Initiative as well as with our, what was at that point, with preparedness, now Office of Readiness and Response, to ensure that there was a lot of synchronization of the expectations around both preparedness and certainly around surveillance systems and data modernization and interoperability opportunities.
Well, it makes me think, do you feel it's an incentive to be accredited then because of the focus on interoperability, especially as you're pointing out to data sharing and ensuring that we are all, no matter how small of a department you are at the local level versus of course state level, to be able to have the data that's necessary, to take care of our communities.
I think the accreditation standards were being looked more as a tool to be moving in the right direction and as a lever to further advance the DMI interests and opportunities. And the same goes with, the same point can be made with some other areas where that accreditation content has increasingly addressed, such as equity, health equity, and workforce training opportunities, and partnership development. So it's been a raising all boats and continuing to raise the boats of those that are already on the ocean, to continue that analogy. And so I think it's less of the incentive. I do think this gets us to the incentive point in terms of for those that are accredited, what could be asked for and this is an area that we've looked at within CDC, application processes or, the connections with expectations in NOFOs or for grantees and how that may relate to something that they're already doing for accreditation or vice versa.
I would just add to Liza's, thank you, Liza. I would just add to Liza's point, ideally, we'd like to see all of these efforts really sort of working together. So as Liza mentioned around looking at our NOFOs, internally at CDC, we've established a new grants governance board so that we can look at, how do we use this to really support the field in the best way, either through streamlined processes or, really learning what we're hearing from the field to make sure that we're doing our best there. And then our work with our colleagues on the data modernization initiative, for which we are, collaborating with them and thinking about funding that goes out, as well as the standards and measures, as Liza mentioned. So all of this, the partnerships, the funding, the technical assistance, and the work around data and readiness should be working together to really support the field in achieving those capabilities that help them best serve and protect their communities.
Thanks, Les. Thanks, Octavio. We're running short on time. I do want to ask you a question, Les. I've had the opportunity also of hearing you speak on this before. And so in reflecting on it, I'd like to gently raise an issue of whether we are thinking about evaluation of this program correctly. My history here is that those early years of accreditation, I was the state epidemiologist in Oregon. Oregon has wonderful public health workers, but it has a mix of health departments, some of whom are highly competent, some of whom, particularly in rural and frontier areas, just are not financed to be able to provide core services despite how good the workers are. Yet any county in Oregon can hang up a sign that says, we have a health department and here it is. In that context, I am not sure that our goal should be simply to get all health departments accredited. More, it's how do we make sure that health departments have those foundational capabilities present that would enable accreditation. And currently, there are many health departments that do not have those, and so should not be able to get accredited. When we're thinking about evaluation of accreditation, to me, I'm not very convinced actually that the process of going through accreditation is necessarily going to make my health department better. I would like to believe that if I'm able to pass that process, that I'm able to provide those 10 essential services, in contrast to health departments who are unable to become accredited. So when we're thinking about whether or not accreditation is successful, I'm a little puzzled that we should be focusing on, did it make a difference in those health departments that went through that process versus, given where we are, that some health departments are accredited and some not, can we show there's a difference in delivery of essential public health services between those health departments that have been able to be accredited and those that are not? That's going to be the most powerful, I think, evidence that we're accomplishing something with accreditation by separating out and showing those health departments that are able to do their job, and potentially among those that are not accredited, pointing to those that are going to need some work, not in becoming accredited, but rather first in achieving those foundational capabilities.
Yeah, thank you, Dr. Fleming. Really great points. And it is something to consider in terms of evaluation. To your point about the approach that we've used to really hear from those who have achieved accreditation, whether or not they perceive that the quality of their services and their accountability, transparency, all of those things have improved. That is a real question that we should think about how to fund. Now, I mentioned the previous current studies underway that FAB is looking at. They're actually looking at impact. But again, I believe those studies are directed towards those who have already achieved accreditation and not really sort of spacing this out or dividing those, as you mentioned. That's something we'll take back and think about. Really great. Thank you.
Thanks so much, Les. And we are out of time, unfortunately, on this session, but really appreciate your willingness to come to the committee and present these issues. I think this has been a really good discussion, and we look forward to hearing from you in the future for how things are going. So thanks once again, and we appreciate, we appreciate you being here virtually today. So,
thank you. Always a pleasure.
Always, it's great to have you. And we are at break time. we will reconvene with mental health and overdose. Thanks very much, folks. Many of us have been looking forward to this presentation on mental health and overdose. We have two expert folks to talk with us, Deb and Allison. I'll start with Deb, and then we'll move over to Allison Awadi, who is 1 month into her role as the Center Director for Injury Prevention and Control.
Thank you. And if we could go to the next slide. So as Mandy mentioned this morning, one of our priorities is mental health and overdose across the agency. And I think this really builds nicely off the work Injury Center did years ago when they stood up an opioid response coordinating unit that has now actually morphed into something called a behavioral health coordinating unit. And that's to really help across the agency pull the work and the strategies from the different centers into a unified approach. That's really, I'd say, a baby unit right now. It's in its incubation stage, but over the next couple of months, as we get permanent leadership in place there, it'll really help lead a lot of these efforts. I know Charlene presented to y'all before on collaborative initiatives. The collaborative initiatives related to mental health. Oh, and look at that. I didn't even need a prompt. And substance use will be part of this. And similarly, we participate as a center and an agency in a lot of the HHS efforts. SAMHSA certainly leads on things like services, NIH on research, but we really bring the data and a lot of the community level interventions. And we co-chair the suicide prevention work group as part of the behavioral health coordinating unit. One of the things that Allison and I are really going to be tackling, including today at our first agency-wide meeting, is looking at things like our data. Since Mandy also mentioned the number of systems we have, I have 60 pages of information on our drug overdose, and Niall's laughing, mental health data. And we're going to look at what are some of the ones that we can tweak to be more timely, to be more forward facing with dashboards and visualizations and interactive. We're also going to look at things like our funding announcements. So it's not just money that's going out to the field, but how are we evaluating it? How are we able to be nimble like drug overdose has been as we've seen evolving changes? And then we've also looked at research priorities across the agency, and we want to see what progress we're making on those. So that's how this fits together as an agency level approach. I'm going to turn it over to Allison to now talk really about the Injury Center, because that's where the focus of much of these efforts lie.
Yeah, thanks, Deb, and nice to see folks again about a month in. So be getting your questions ready, and I will do your best, but in some cases, maybe follow up afterward. So you can move to the next slide. We're really excited about this idea of having improving mental health be one of the priorities.
Excuse me, please use your mic.
Oh, sorry, there we go. Sorry about that. So we're excited about improving mental health being one of the priorities for the agency. I think it is not the most obvious choice, frankly, for CDC to take this on, but I think it does reflect where the country is, where the needs are, where the gaps are. And within the Injury Center, we have 3 priority areas that clearly touch and contribute to and are affected by that mental health priority. And that's preventing overdose, preventing suicide, and then preventing ACEs, adverse childhood events. I'm going to show you just one slide briefly on each of those areas that's going to highlight, first of all, tiny bit on the data, but then a lot about how are we really funding and moving data to action, which is our goal as a center, is our goal when we're thinking about mental health. And also want to set up for you how we're really thinking about prevention activities. Again, carving out CDC's role explicitly in these spaces is important. Lots of partnership work, as Deb said. So you can move ahead to the next slide, which starts with overdose. So I don't have to tell this group, this is an enormous and growing problem. 112,000 drug overdoses every year is our most recent data. That's more than 300 deaths happening a day. It's the #1 cause of death for adults ages 18 to 45, and it's only getting worse. There was just a paper out in the last couple of weeks that showed that in 2010, just to give you a sense, for every 20 times people were coming to emergency departments for non-fatal overdoses, we were seeing 1 fatal overdose. just between 2010 and 2020, that ratio basically went in half. So now we are seeing 10 non-fatal overdoses in the emergency department for every fatal overdose. And so in effect, the pathogen, if you will, is really getting a lot worse here, where we are seeing especially illicitly made fentanyl just driving and making the drug supplies and the drug use so much more dangerous than it has been. We're seeing much more combination with stimulants, whether that's, methamphetamine in the West, whether that's cocaine in the East, whether that's counterfeit pills, much more likely for overdoses to end in fatalities. And so it's more and more important in that prevention space for us to be thinking upstream, for us to be preventing overdose and really staying on top of data. So on the left here, this is really one of our flagship programs and cooperative agreements. It's called the Overdose Data to Action. The first release of this was in 2019. So this is also relatively newly funded work. And we've just released a second round this last September. And newly this last September, we are now funding both all of the states that applied, everybody except North Dakota is being funded. And we are now funding 40 local jurisdictions, or in some cases territorial. And there's the work of this grant. You can see it's almost $280 million. It's a lot of money, is to really build the data infrastructure and then the data to action work on the ground. I can tell you as a former recipient in Chicago, this was really critical for us getting some epi basics going, for us building partnerships, experimenting with what data actually could drive the needle. And we have lots of examples of how people are using this funding to make data more timely, more comprehensive, more actionable, and then building the evaluation pieces in. Just as one tiny example in Louisiana, where we saw work similar to what was done with other grantees, but they pulled together folks from hospital emergency departments, law enforcement, first responders, the coroner's office, a harm reduction team, and said, we're going to get a team together. We're going to choose where are our gaps? Where are we having the biggest spaces? They said, we're going to really focus on hospital emergency departments and make sure everybody's going home with naloxone in this parish. And they saw the next year a 35% reduction in overdose deaths within that parish. That's the kind of thing we want to see on the ground. On the right is just on each of these three, I'm going to highlight that in addition to the funded work, the team in the Injury Center has really been working to make sure that we are lifting up the best evidence. And this is really meant to be for communities and partners to use. We're rebranding these. They used to be called technical packages. We're rebranding them as resources for action. And the idea that there are things in the overdose space that work, that have good evidence. There are some things that actually don't work very well and don't have good evidence. And where a lot of states and locals are getting opioid settlement money, for example, we want to do what we can to really ensure that the decisions they are making, even if it's not the work we're funding, is going into prevention work that has evidence behind it and is a data to action framework. So that's overdose. On the next slide, just very briefly on the suicide. This also not going so well in terms of outcomes. We're up to about 49,000 suicide deaths annually. It is also going up between 2% and 3% a year, just like overdoses. And I will just highlight that, that is about 135 suicides every day in the US. I'll also just note this pretty sobering statistic from the YRBS data in 2021, where 1 in 10 high school students reported that not only had they thought about, but they had actually attempted suicide. And this is, of course, in people who were there to take the YRBS, that following year. And we know that suicide really lands disproportionately on certain groups. Veterans, very high risk, rural populations, men in particular, tribal populations, and then youth. And so similarly on the left, this is about some of the data to action work that we're funding. We have 24 grantees for the Comprehensive Suicide Prevention, the CSP grant. You can see this one's about $21 million. So it's less than 10% of what we have have for the overdose work, but it's critical. And on the data side, this is doing things like recipients are able to actually look at emergency department data, syndromic data, for people who come in for suicidal ideation or suicidal attempt, and then say, what do we do to make sure those folks are getting into the care that they need, the prevention, the treatment that they will need to stop that from becoming a completed suicide. But there's also lots of work. On the right, again, we've got the resource for action, whether people are funded or not. And there's coalition building work around this. There's lots of work with thinking about how do we take away stigma around this, make sure that folks, certainly healthcare providers, but coaches and faith leaders and teachers and others have some more ability to sort of talk about this, recognize this, have it be a piece of what we're doing. And so again, CDC is very focused on the prevention space here. And we know that mental health is not the same as suicide, right? Mental health is a contributor, mental health condition is a contributor to a suicide about half the time, a little more than half the time. And there's a lot of impulsive things, whether it's a relationship issue, whether it's a job loss, whether it's a monetary type thing that will often drive a decision, around a suicide attempt. And as we see the lethality go up of what people may be choosing, we may see more completed. So there's work to do on that side, but also that there is lots to do actually on the prevention side. And the last thing I'll say about, oh, sorry, we didn't go to the suicide. Oh, we did. Okay, we can go forward to the suicide one. The last thing I'll say, and Deb mentioned this, is that in the same way that we've got this data to action framework happening with our grantees, where, in Michigan, for example, they funded a suicide prevention media campaign that was focused on a particular group of men, and were able to show statistically significant that people who had been exposed to that were actually more likely to seek care. This idea of not just doing something, but evaluating it. At the national level, in April, likely, we will be releasing the White House's new national strategy for suicide prevention. This is co-led between CDC and SAMHSA, but it involves all the agencies. It's a 10-year strategy, but also there's a 3-year action plan. And for the first time, the federal agencies, not just the HHS ones, but agriculture and labor, et cetera, are committing to actions around suicide. And it's a big deal. It's exciting. And we want folks to know about it and have penetration and know about the resource for action. And then finally, the last slide, if you can go ahead, thanks, is around adverse childhood experiences. And you might wonder, why is this in there? Like, this doesn't have maybe that same immediate feel of, I'm counting this many people dying every year. But we really think, particularly from a data to action and a prevention lens, that the adverse childhood experiences lens is an important one. I presume you all know ACEs, sort of know that data. It's really pretty remarkable where if we could do the work of preventing those ACEs, having some of the PCEs, the positive childhood experiences, to balance out the adverse childhood experiences, we would likely be seeing big impacts on later adult, chronic health, physical health conditions, substance use, depression. There was an analysis that, if you were able to eliminate a certain number of these adverse childhood events, we'd see 44% fewer adults being diagnosed with depression, for example. And when you're thinking about our inability to treat our way out of the mental health crisis, that prevention piece is critical. And so, nearly 2 in 3 adults have experienced at least one of those events. But as the numbers go up, of course, the risk goes up. And similarly, on the left, we do have a program. I'll note this is about less than $6 million as compared to the 280 that we have for overdose. But we do newly have 12 recipients, and you can see it's a mix of states and in some cases, hospital systems, et cetera, that again are working on data, driving into action. On the right, we have a new resource for action that's an up-to-date around what is the evidence around this for what works. Just an example of how this is being used in Georgia here. The recipient on the left was able to look at some regional level ACEs data and then use that to really drive interventions for early childhood home visiting in parts of the state that had the biggest gaps. And so, overall, I hope this just gives you a little bit of a sense of how we are attempting to tie in a lot of the work and the funding and the work to get this out, to turn data into action, to tell the story of prevention. Suicide, overdose, and ACEs, these are relatable, these are related, these are preventable, these have a huge amount of impact, and they all link into the mental health crisis. So appreciate the interest, certainly want to hear questions. Deb and I will take them together. I'm interested as we are thinking about more explicitly talking about the mental health work, how we frame that, how we make sure we're doing a good job of differentiating CDC's role in this larger piece. And also just curious about thoughts you might have about the ACEs framing overall, where we're making some decisions about how central this perhaps should be as we're prioritizing this work. And with that, I will stop talking and appreciate questions. Thank you.
Thank you so much. That's fantastic. Colleen.
Yeah, just on that last point of differentiating CDC's work, it makes a lot of sense from where we sit, why CDC should have a focus on this. I'm not sure that in the broader world, people understand that. And so in your month here, what is your sense of how that is being received? And, kind of how are you thinking about differentiating yourself from SAMHSA and HRSA and others who are involved in it, and being clear about that?
Yeah, I think there's a few things. One is I want to be careful that we don't always define CDC's role as what we are not. I think there is a tendency to say we are not treatment. And when you start with what you are not, you're already starting on a back foot. I think there is, and we've got examples from sort of all over the country. Again, the overdose space has had a little more funding, a little more ability to think about implementing things in a broader way, building some of this evidence base broadly around what that prevention looks like, what that harm reduction looks like. How does that then apply to some of these other areas? But I think it's a little bit of an uphill battle. I've been interested as I've been having some of, I had a call with one of the, with a legislator in Washington who right off the bat started talking about ACEs with me, which I was a little bit surprised and very pleasantly surprised to hear. That's been work that the Injury Center has been working to kind of build and grow. But it is not, prevention is always the hardest thing to show the evidence because something hasn't happened. And we've got some economists who are thinking about how to tell that story better. We've got some, folks who are thinking about large data and how you better shape this and tell the story. But I think there's a long way to go. And I think even across CDC, there's not always as much of a recognition that you can take prevention strategies that have worked in an infectious space, and move them pretty well over and think about care cascades and think about where people are falling off and having standardization. And all of this helps fit the non-infectious spaces into a place where people do understand a little better anyway, public health's role. But we really have an uphill battle. So ideas or thoughts around that are most welcome because we're trying to figure it out.
And just comment that you also touched on, I think this is an area where being able to work with other disciplines, you mentioned economics, but I think more broadly, the impact, I think, will also help to elevate, CDC's role in this by really showing that kind of interdisciplinary, intersectoral sort of a lens as well.
Yeah, I agree. And what I would just add is particularly for things for our overdose work, we've worked really closely with public safety. So, partnering through some of the drug control strategies, like Allison said, I think it's showing what we are doing versus what we're not doing for things like suicide and ACEs. They're all relatively young programs, though. I had made suicide and ACEs priorities when I was at the Injury Center. We didn't have lines in either. And overdose has only been a line since 15. With suicide, one of the things we have focused on too is more of a community level approach versus individual level. And that has helped us around differentiation. And I think the more that we can just talk about how we're using data in innovative ways, people always understand that CDC is the data source. My only issue is I don't want people to think all we do is data. And that's why I always think it's important to say data to action. And like with drug overdose, we've done a lot with now checking like syringes for what substances are in them. So that we saw like xylazine was coming out and we were able to then do some of the clinician calls on it. So really looking at novel data sources that then we can use and say, here's some strategies. Like even with suicide, there was something called the blue whale game where youth were dying, but we were able to focus on that and say, here's what you do.
This is also an area, and I don't know how much you're doing, where I think there's a lot to learn from global experience.
Yes.
So
yes. 100%.
So we'll go to Octavio, then Daniel, then Josh.
Thanks, David. Yeah, this is Allison, Deb, this is really exciting for me as a psychiatrist, obviously, and running a foundation for mental health. So yes, I think CDC, this should be spot on. This should definitely be in your wheelhouse. I think there's a huge role that you can definitely play in what's going across this country. Because I think the entire country right now is in a mental health crisis and has been actually for quite a while. It's just accelerating. And we continue to go down the wrong pathway. Definitely agree with my colleagues' comments and points. I would like to add some additional ones. I think it's exciting about the data part, but also I think you can do more than that. In the sense of, to me, ACEs fits in to me very logically. It is not to me an outlier at all, because it really does get you upstream into prevention, much more so. But also you mentioned, Allison, about the National Suicide Program, the interrelatedness of at a systems level approach. I think that needs to go across all three, not just number two, which was the suicide, but it definitely is obviously overdose. We do this thing here in America with our healthcare system. We have a tendency to fragment and to silo ourselves. Whatever you can do to break those silos, and especially from partners, to think about not only the data, but also the impact they can have, but the understanding of why they should be related to what the CDC is looking at and was proposing. As an example, as you were talking, I'm thinking about ACEs and prevention, understanding and the utilization of some already indexes you already have, like this, the SVI as an example, social vulnerability index. Another one would be the area deprivation index, because we all know if you overlay those maps, where are the suicides happening? Where's the mental health crisis really at a critical juncture? Where are our institutions of health and in public health overwhelmed? I guarantee you it's one of those spots. So we need to start using that data and that understanding, but then tying it to, and you mentioned like economics. Work with the Federal Reserve. They do some wonderful reports when it comes to the area deprivation index and how economically we also are not addressing these very issues, because that is what is happening with suicide. We're having death and despair in this country, folks. And there it has just been increasing the percentage of our populations. First, we could identify, and it was unfortunately impacting our communities of color. It's impacting our rural areas, but now it's our veterans, those that feel that they are not being, taken care of by the country that they fought for. I mean, and the list goes now on and on and on. And the number of folks that are economically one paycheck away from being homeless is leading into this as well, this death and despair that unfortunately we're experiencing. And unfortunately, our healthcare system is not a prevention system. And I'll say it's not even a health system. It is a system that takes advantage of illness and death. And that's where we make our money. And it's unfortunate that we're not willing to move more up to actually health and prevention. Whatever we can do to connect those. And I know it's a lot, but to me, the CDC is very well made for that, because we are about disease control and prevention. And so wherever any of the indices you've already identified it, and the CDC has already helped develop, and others that exist out there to help different systems understand why you need to be connected to us. Why does, housing, why does HUD need to be at the table? Well, why does the Department of Education need to be at the table? Why do we need to have, as an example, as was mentioned, economics? And I totally agree about the global aspect. There's so much we can learn. Take a look at how suicide rates have been decreasing in other developed countries compared to ours. And once again, we're being left behind. I'll stop there. Just saying, you're on the right track, and I love it.
Yeah, thanks. And I didn't mention, just for some context for folks who I don't know, I'm coming from about 10 years at the state and local level. I was most recently in Julie's old role, leading the Chicago Department of Public Health. But in those spaces, the behavioral health work is much more combined, right? Like the mental health, substance use, violence prevention teams sort of are the same team. And I think thinking about broadly, across the agency, how we are really pulling this, telling that story, those pieces. I appreciate, I've got a couple of suggestions here for follow-up. So thank you for that.
Oh, and there's one else to say, because you said it, or someone did, which was lovely, which is community engagement at the community collaborative level is going to be key.
Yeah,
absolutely.
Wow, thanks, Octavio. We'll go to Daniel.
Thank you so much, David. Absolutely echo all that we've heard, those comments, and I want to applaud you all for prioritizing these issues. You know, on the hierarchy of value that we place on chronic diseases, it's really refreshing to see that we are elevating this issue, especially around suicide. One of the things that I heard, though, that I guess I didn't hear, was when you talked about suicides and the 49,000 individuals who lose their lives each year owing to suicides. We talked about veterans, tribal, youth, rural, but there are two other population groups that are disproportionately represented in these numbers. One that's quite alarming to us, Black youth, Black children and youth in particular, as well as LGBTQ plus youth. And I'd love to understand, what are you all doing to address the disproportionalities among those two respective population groups as you're focusing on upstream interventions?
Yeah. What's that? I can start and you can add in. Yeah, I mean, I will say, you know, again, new to that national space, certainly where I'm coming from in Chicago, we were seeing big increases, particularly among suicide in African-American populations, including youth, you know, learning how some of that fits in. The LGBTQ part, I didn't get into it for time, but a lot of, you know, in the funded jurisdictions, there's work to sort of say which populations are being the most left out in our work. Where does that look? And there's a whole team. I just had an internal meeting with my staff, and we pretty much spent the whole time talking about what does that LGBTQ work look like, you know, in the mental health space overall, but then specifically in each of these other ones, including suicide. So I'll just say that high level, Deb, okay. But yes, absolutely hear you. I think also where we're, you know, there's of course overlaps to the firearm data. There's overlaps to other pieces here. I've just given a little bit of it, but I think where we are looking to sort of grow interest and support, you know, in a less politicized kind of way, I think something like suicide that is landing very heavily on urban areas and rural areas and in these different groups, like there's a lots of pieces in there. But we want to make sure that folks are developing interventions where we're funding them that are based on the impacted community or group of community and have that equity lens then around the interventions. So thanks for that.
Yes, thanks. And thanks so much, Dr. Already, for that great presentation. I have a question, which is on overdose. And, you know, when CDC was concerned that there was overprescribing of opioids, CDC didn't just send, you know, best practice, create your overdose prescribing guideline, you know, out. CDC actually wrote a best practice overdose prescribing guideline that was very influential. You know, in the past, when antibiotic overuse was an issue in my field of pediatrics, CDC wrote a guideline on the appropriate use of amoxicillin versus other medications. And given that we know, you mentioned naloxone in emergency departments, so we know that drug treatment, including as well as naloxone, are really, there's an enormous gap in the ability of the medical community to provide very effective treatments to people for addiction. The medical community sort of owned up to its role, I would say, in the creation of the opioid epidemic, but maybe not so much to its role in addressing people with addiction. Many people go and don't get offered effective treatment when they're hospitalized or in the emergency department, despite national guidelines that exist, despite, you know, legal analyses that suggest they may be violating the ADA, despite entreaties sometimes from medical students and residents. There's just still an enormous amount of stigma in medicine that prevents effective care and life-saving care from being offered. And I wonder whether, as you think about the different things you could do, whether a set of expectations that CDC could create for the medical community might be helpful, like it was to address inappropriate prescribing or, for pain or antibiotic resistance or other things that whether you're open to getting, becoming part of the voice and really a leader of the voices to the medical community for what it needs to do to help.
Yeah, I think it's an important point, this thing of where do we go beyond resources for action maybe, or what might be the next step on that. I think the point, you raise this interesting question of there is such a gap between the need and actually people getting connected to the evidence-based care, not just the naloxone and the harm reduction, but that care. That we've seen OD2A recipients, for example, we've seen health departments stand up with their hotlines that may be more broadly for opioid use disorder for anybody to call, the ability to get same day connection to buprenorphine, right? To like make sure that we have a care coordinator who is ensuring that the pharmacy will actually deliver that to somebody's home, that they can get that prescribing for the first 2 weeks. And we've been able to see some of those practices go statewide in a way that can really help folks living in rural areas who perhaps are not able, there may not be in-person substance use providers, and folks who in urban areas, perhaps, it's so hard to navigate the system at baseline. But we don't have enough providers. And I think, in some of the earlier stages here, health departments were funding a lot of X waivers and we're sort of trying to do a lot of education. But there's a really long way to go. And to me, even though we are not funding the treatment, right? SAMHSA is funding the treatment. There's tons and tons happening there. I do think that space around being able to link to that care and then be retained in that care, where we know things like when people are released from incarceration, it's a huge moment of risk for overdose. What does that actually look like from a prevention standpoint? I do think that's a space where there's more ability for public health to kind of step in and lead.
Yeah, I totally agree. I'm saying something a little bit different, which is that CDC uniquely has spoken to the medical community about what it needs to do to rise to challenges like this. That's what it did on prescribing. It has not done that on treatment at the medical community level. Nobody has really done that, I think. This is just my opinion. So I'm not trying to single out CDC, but CDC could, not just fund programs that do this work, but have an expectation for emergency departments to provide buprenorphine and primary care clinics to provide treatment, and really expect the medical community to do for addiction what it does for other chronic conditions like diabetes. And in the past, CDC has been very influential at that level. And it is kind of a uniquely CDC level to talk not just to the addiction specialty community, but to medicine about what those expectations need to be for a situation, a scourge that's killing 112,000 Americans a year. And I realize that I do think that I'll just say, I think that this is a moment when there's plenty of fertile ground for that. You have like the American College of Emergency Physicians as a practice guideline that's often not followed, or a set of recommendations. You have the Department of Justice starting to sue jails for not providing treatment. We funded analysis at our school that suggested that they should be suing hospitals, frankly, for not providing effective treatment that can reduce the risk of death by 75%, but there's not a engagement with the medical community at a high level to set those expectations, in addition to funding projects that may be good in different areas. Anyway,
yeah, thanks for that. And Deb, I'll let you chime in. It feels like something that could be a joint CDC SAMHSA potentially, where you're
there was an
wanting
astute Dr. Olson or an astute Dr. Olson that I was going to connect Allison with that might know a little something about this as well at SAMHSA. That as we're doing, as we're working with different federal agencies, Allison and I are doing like some meet and greets with NIH and other groups. And so we can add this to our list for sure.
Yeah, it's a good idea. Thanks.
Thank you. This has been a great discussion, great presentation.
As we wrap it up, as we wrap it up,
and we're short.
And I was going to say too, I just want to give Allison like huge kudos because literally she's been in this role 1 month. She had big shoes to fill, when Chris Jones left, and I think she's off to a phenomenal start. And I have the best of both worlds because Sam Posner, who was acting, is now our permanent Office of Science Director. So I have all of my colleagues around me, which is great.
All right, it's going to be a very provocative question. I'll just preface it with that. David.
Allison, as a kid.
So Allison's going to have to answer.
Gun.
But it does really make me think of, as I've heard all the comments, and including reflecting on my comments as well, how far upstream are you willing to go in prevention? Which means, what about structural racism? Because we know the impact that it's having.
Yeah. I mean, I think that is central to this work. I think depending on the audience, you might use different words, you might frame things in different ways. But I think if you are not talking about that, and if you are not talking about, equity for real, I don't think you're being true to the work of the Injury Center, like truly. And so, this has been a conversation, of course, I am coming from Deep Blue Chicago, where this was an easy conversation and sort of an obvious link, and making that transition sort of in my own mind and with my team about how you keep this really central, because I think it has to be for these issues. And it's important across CDC, but for these issues in particular, I think it's critical. And I think we will be making sure that that remains part of our, not just our messaging, but our work and our funding and our patterns, while we ensure that our work remains relevant to folks from across the political spectrum. So that's my opinion. And that's something that, I know my team feels strongly about, and we will be working on what the language around that may mean in different settings. But I don't think that's provocative at all. I think it's central to this work.
Well, coming from Texas, let me just tell you.
Yeah, exactly. Right. Like this is the challenge. And this is where, for me in this role, it's one of the biggest adjustments that I'm needing to make with my team. But I also believe so strongly that on these issues in particular, whether you're talking about putting resources where they're most needed, whether you're like, there's ways to talk about it, but you've got to talk about it, I think. And it's got to be a piece of what you do. We're never going to get on top of these problems otherwise.
Appreciate that, Allison. And I mean, bottom line, it really is not fair for our children and youth here, no matter what community you're looking at. Thank you.
Amazing points. And as you're thinking about this, please engage with your other fellow CIO directors, because this issue is not one that stops with these areas. And to the extent that CDC can have a unified voice on issues like structural racism, it will really go a long ways.
Yeah.
And I cannot wait to see if you're at this level 1 month into this, where we're going to be a year from now.
I have a
Please.
very good team, and I like this work. Thank you all so much for your comments and input and ideas. Really much appreciated.
Thanks so much. Okay, we're going to move on to the last discussion before lunch. And this is going to be an update on the Center for Forecasting and Outbreak Analytics. Dylan George is presenting to us. Thanks so much for coming today, and we look forward to the presentation.
Thank you very much for the opportunity to talk with you all today and to give you an update on the Center for Forecasting and Outbreak Analytics. For those of you that don't know me, my name is Dylan George. I'm the director, and a handful of my team are in the room with me as well. If you aren't familiar with the Center for Forecasting and Outbreak Analytics, we are one of the newest centers here at CDC. You can think of us as a startup in government. We're at the early stages of building out the team, the tools, the processes, and the partnerships as we're going forward. First slide, please. Thank you. I'm very grateful for the opportunity to give you an update as to what we've been doing in the last little while. In 2023, the Center for Forecasting and Outbreak Analytics developed our 5-year strategic plan. And we were in that plan, we were outlining our long-term vision, mission, and goals. Our vision is to empower people to save lives and protect communities from health threats. Our secret sauce, our mission in how we're actually going to realize that vision, is to harness cutting-edge analytics to improve response capabilities for public health emergencies. That's how we're going to actually make a change in the world. We were born out of the pandemic. We were born out of an explicit recognition that we need to use data and analytics much more effectively to generate the evidence base to keep Americans safe in a time of crisis. And now, just in our second year of operations, We have already made significant progress in driving technological and analytical innovations. And what we're trying to accomplish is trying to create a future where infectious disease forecasting is as common as weather forecasting is today. From responding to outbreaks with actionable data to creating an industry-leading disease forecasting modeling for influenza and COVID-19, CFA is building our national capability to use advanced analytics in a time of crisis. Next slide, please. To fulfill our mission and become the trusted source of outbreak forecasting and analytics, CFA needs more than just cutting edge tools and technology. We need good people and sustained support. You can see from this slide, we were started in November of 2022. At its inception, CFA was represented, 2021, excuse me, a critical investment in our national public health and national security infrastructure. And we continue to grow a world-class organization. It is critical that we maintain sustained funding moving forward to support our innovative work. We started out with multi-year funding in the first year. This was supplemental funding, $200 million from the American Rescue Plan. Congress then established us, authorized us, and appropriated a line for us in 2023 with $50 million. And about this time last year, the president came out and requested $100 million for our base funding in appropriations. And this is the level of funding we anticipate we'll need to sustain our capabilities going forward. Now, CFA's success relies on good people. We are working to attract and retain an ambitiously technically excellent, creative, and diverse workforce. I often refer to the team at CFA as crazy good. They are amazing. We have attracted people from industry that have left, quite honestly, higher paying jobs to come work with us because they believe in the mission. We have attracted people that have left tenure track positions. We have attracted people that have foregone tenure track positions that we know would have gotten really good academic positions. It is a crazy good team, and I am proud to be associated with them. Now, when we launched in November of 2021, we just had 5 people. 6 months later, we had 8 people. Then a year later, we had 25. Now we're at about 70 people. That's about halfway to where we need to be fully operational going forward, but we've made significant strides in generating a crazy good team going forward. Next slide, please. Now, our work last year can be summed up simply, we use better data to create better analytical tools and focused on collaboration to amplify our impact going forward. So wanted to give a couple examples in each of those buckets. Better data and analytics, better models and forecasts start with better data. We all know this. We all have seen the CFA relies on high quality data from the Data Modernization Initiative. My colleague Jen Layden has briefed you all in the past about what they're doing with the Data Modernization Initiative and the Public Health Data Strategy. And it is critical that we build on those efforts and the successes that they've had. Incorporating these new sources of data in the last year has improved our models so that we can make more robust predictions about disease outbreaks that we could not do before CFA existed. Now, I'm going to give you an example of this. Wastewater data. Wastewater data is a new and transformative data that is very exciting within CFA, within public health generally. Now, there's a lot of excitement about it. We are, I think, reaching the height of anticipation. We're going to hit the trough of disillusionment, and hopefully we'll get to the plateau of performance going forward. But through the ongoing collaboration with our colleagues in NCIRD, the Data Office, EZID, and the Global Health Center, we have used wastewater and syndromic data to develop state-level forecasts for COVID-19. We have found by layering in wastewater data, we see more accurate forecasts. Now, this makes complete sense because it's a leading indicator of what's going on with circulation in the community. And it helps us know when there's going to be peaks or troughs going forward. This has been a major advancement that wouldn't have happened as fast if it weren't for CFA being in existence. We're also making advances on how we use data and improve our forecasting capabilities broadly. CFA has refactored the code that was used for COVID forecasting by the response team. We've made it much more robust, portable, reproducible, and efficient. The models that are used for COVID-19 forecasting, they run 10 times faster and with better data processing so partners can respond to future outbreaks more quickly and more efficiently. These new data sources and processing techniques and methodologies solve key problems in how we understand what's going on in our hospital systems. Better data leads to faster and more accurate models, which leads to better information that people can use to keep themselves, their families, and their communities safe. That's better data and analytics. In the middle bucket, better tools. To translate these complex forecasting models and analytics for decision makers across the nation, we have created new decision support tools for the state and local level. One of the things I want to highlight to you is the respiratory season outlook. In October of 2023, we released the first respiratory disease season outlook, providing timely information to decision makers on how to prepare for the fall respiratory season. The outlook was based on scenario modeling hub data results for COVID-19, influenza, and RSV, and predicted that there was going to be a similar amount of total hospitalizations in 2023 compared to 2022. CFA shared this outlook broadly on the website through media, news outlooks. We also, Adrian, who's here, who runs our Inform group, did a brilliant job of making sure that we are connecting very closely with our state and local, territorial, and tribal partners to make sure that they understood what it meant and how to use it going forward. This equipped them with the knowledge to know what to expect in the upcoming year and to have targeted conversations with their hospital systems so that they could know if they're ready or not. If they were ready, great. If they weren't, let's dust off the plans and think about how to do it a little bit better. That was a nice advance. Flu site influenza modeling is another advance. In November, CFA began submitting weekly forecasts to the CDC Flu Site Influenza Forecasting Challenge. Now, this is the first time CDC has ever authored and publicly released forecasting results. Now, you may say, well, we've seen these forecasting results on the CDC website for a long time. Those were submitted by academics or private partner into CDC. This is the first time within CDC we have generated those on our own. This is a major milestone, a major step forward in our driving our capabilities. Jason Asher, who's here, who leads that team, has done a brilliant job galvanizing how we move forward in that space. Now, ongoing outbreak monitoring as well. We have had to build the plane as we were flying it. We had to chew gum and walk at the same time. Whatever analogy you want to talk about, we had to do multiple things at the same time. Every organization has to do this. We were growing and trying to help out at the same time, but we have definitely been able to help out with a range of different outbreaks from Mpox, Marburg, Ebola, cholera, COVID, and a handful of others in helping out with the response capabilities going forward. Our ongoing work in developing and sharing better analytical tools has given decision makers more timely and actionable information during response times. So we're very proud of being able to help out in a more robust way. Now, the last bit, this increased collaboration. As CFA continues to grow as an organization, we are building partnerships across sectors to help develop, test, implement, and share data, models, forecasts, and analytics. We have co-led a combined force with our colleagues in NCIRD to lead CDC's 2023 Respiratory Virus Response Modeling Task Force. So within the IM structure, we were the ones that were helping lead that work to make sure that you didn't have to beg, borrow, and steal across the centers anymore. You had an automatic group that was helping out there. In global collaboration, again, Adrian, who's in the room here, did a beautiful job moving outside of the United States. CFA fostered international partnerships to develop new risk assessment tools. We've been working with WHO, PAHO, ECDC, the Public Health Agency Canada, UK Health Security Agency to actually galvanize and generate better risk assessment strategies and tools going forward. And the reason that we were doing that is because helping develop these strategies and tools will enable us to talk with our state and health and local health partners as well on the potential risks and galvanize a better approach going forward. So we're very excited about that. Now, I did want to point out on next slide, please, a couple key things that we had done going forward. This is the famed RT estimates. This is RT is an estimate of growth of a particular outbreak. And so R naught or RT is the how many infectious individuals will be generated from one infectious person. This is referred to as the effective reproductive number. It's a measure of how disease spreads efficiently within a community. We released the first public COVID and influenza growth estimates for every state. This is the first time that this has ever happened. The RT it has been publicly released on the CFA website in this user-friendly color-coded national maps and are updated on a weekly basis. So one of the things that's been really useful about adding this on, just as a personal note, when I was talking with my own members of my own family, I could point to them to maps of what is the circulation in your particular location, what is the status of COVID influenza in your particular location. Then I could point to these maps and say, what are you going to anticipate in the next handful of days to weeks in terms of a growth or decline in the COVID or influenza in your area? That helped them understand what was the risk that they were going to be confronting and assess what was their level of behavior that they wanted to change and how they would go forward. So that it was a tool that was helpful for me in talking to my family. I am very confident as we progressively make this much more available and understood, it will be a tool for many more families across the United States. Next slide, please. The other thing I wanted to do a little bit more deep dive onto is this thing that we refer to as InsightNet. To speed up innovation and progress on new tools for state and local public health, CFA launched InsightNet. This is the first national outbreak analytics and disease modeling network. InsightNet represents the largest government investment in modeling public health infrastructure to date. 13 performers and awardees represent public, private, and academic sectors. They are bucketed into three big groups. The first group is the innovators. They're coming up with new analytics, new models, and testing out new data. The second group is what we refer to as the integrators. They're the ones that are working with health departments to validate that it's the new analytics are fit for purpose, that are going to help analyze or make decisions bigger, faster, stronger in some way. The last group are the implementers, because it's only 13 awardees here. It's not a chicken in every pot kind of model. We want to figure out how to make these capabilities much more accessible, usable, and understood by as many jurisdictions as possible. They're the ones that are tasked with scaling those capabilities. So coming up with new innovations, testing them with health departments, scaling them across jurisdictions is what we are trying to accomplish with InsightNet going forward. This is a huge step forward in making sure that we are working closely with our state and local partners to build capabilities at that level going forward, because we know in our federalism system, that's where a lot of the decisions and authorities lie, and that's where we want to work very closely going forward. Next slide, please. Now, we have a handful of goals and a handful of things that we want to accomplish across the buckets going forward. We continue to work towards our goals in using even better data and creating better tools and expanding our access and our availability to our STLT partners. Better data. CFA will continue to use new data and modeling techniques to improve accuracy and speed. We're going to continue working on wastewater data, improving those capabilities. We also are looking at syndromic data. We're looking at emergency department visits. We're looking at ADT data to help us improve the forecast, to help us anticipate how the hospital systems are working going forward. And we're very excited about some of the successes that are moving forward in that space. Better tools. InsightNet is going to be a key part of our goal to advance the system, the tools, and the products. And we will continue to make our primary awardees get stood up, working effectively as a network of networks, but also working very closely with other centers of excellence across CDC. By focusing on rapid innovation, implementation, and systems integration, we will empower CDC and our collaborators to develop cutting-edge analytics effectively and to deploy them in the most effective way. And in 2024, one of our top priorities is going to be working very closely with state, local, territorial, and tribal groups. We want to make much more progress in that space. This includes enabling new modeling toolkits designed specifically for state and local jurisdictions. We also want to expand access to our advanced cloud-enabled virtual analyst platform that modelers at local and national and even international levels can work in a collaborative way together. This will allow us to collaborate, model, file, and code share in a much more rapid fashion, especially during an outbreak. And so, and finally, what I'd like to end with, though, too, is that by continuing to invest in methods, tools, and partnerships, CFA is ushering in a new era of data-driven decision-making in a time of crisis. We will continue to work towards a future where modeling, forecasting, and advanced analytical tools are at the ready for decision makers and indeed for all Americans. And we want to make this a reality going forward. The reason that I left the private sector to come to CDC is because I do believe we are at a transformative moment in history. There's a clear need to use data more effectively. There are advanced technologies that we can employ within public health that are being used broadly and effectively in the private sector. There is a willingness to work on this, as we've demonstrated from the team that we're massing. And there's a need to make sure that we don't have happen what happened over the pandemic again. And so the reason that I left the private sector is because I think that we can make a significant advance in these capabilities going forward. And with that, I will stop and take any of the questions you might have. Thank you.
Thank you for that cogent and passionate presentation. Appreciate it. We'll start with Jill and then Julie and then Helene.
Okay, I want to make a couple of points. First of all, congratulations. Fantastic, exciting. Congratulations. It seems like you're building something that is not disease specific, which has been a real challenge for CDC with their disease specific money. So you're building the infrastructure, which is lovely. And if we can do that in other areas, then that would be great. I also like to congratulate you on your partnerships with academia. Really, really good. Now, here's the challenge that I see. As you said, we're at a transformative time in using new technology. We're also at a transformative time in diagnostics. New technology, much more, the public now has an expectation of home use.
Yeah.
Trouble is the home use tests are not delivering data. Now, how can we incentivize manufacturers to develop a system that is non-identifying? So, you know, I look at zip code, positive and negative, so that you get, and that information is given to the regional health department. So that says, hey, there's something going on here, in combination with data from pharmacies, maybe in products coming off the shelf. So how do we do that?
Yeah. Thank you so much for the question. I think it's we all saw the world that we want to be in going forward, where we have, I mean, and this is a long-term trend. It was just accelerated by the pandemic, where healthcare delivery is moving from the hospital to the home. And in addition, it's like over the pandemic, my GP, he actually retired at the end of the pandemic. And so when I was looking for a new one, I actually found one that was fully telehealth. And because it was really exciting to see, it's like, well, how well will this work? The fun thing that—
Can I interrupt you just for a second?
Yeah.
For a technical issue? We may lose our computer because of a forced restart.
Oh, no.
So I just want to alert the folks on Zoom. You may go down. If we do, with your permission, we're going to reconvene at 1 o'clock or at the top of the hour, rather than at 10 after the hour for the next presentation. Hopefully we'll continue to see you during this presentation, but if not, that's what's happening.
It's not you, it's us. Yeah. But yeah, moving healthcare delivery from home to hospital, and I think is a big trend. And then also it's like this telehealth is, I mean, the box of electronic goodies that they sent me to actually be able to do sensors across was inspiring to see how we do. But I completely agree with you, from home diagnostics and wearables and other sorts of biosensors that are going to be proliferating over the next 5 to 10 years. it's going to fragment the system even more so in how we actually aggregate the data coming forward. It's going to be a very challenging environment to work in. I don't know the answer there, but I'm right there with you and trying to think through how we would actually deal with those kinds of issues.
And so it seems to me that if we can do it in stages where people get used to one level of information, get comfortable with that, nobody's coming to get me, and then have the next conversation. But I
Yeah.
can't see doing it all at once, but we're going to be missing a huge amount of data if we don't do something.
Completely agree. Yeah, 100%.
Hi, Dylan. Thanks so much for your presentation and the update. It's amazing progress that you've made in a very short period of time. I have a couple questions for you. One of the things that you said early on was how you've been able to recruit and hire staff from industry, from academics would have gotten higher salaries elsewhere just because of the commitment and mission and the vision of the organization and of your work. And I'm curious, we've heard states and locals, we've also heard others within CDC, the agency, say they're unable to do that. So I'm curious why it is that you think you have been successful when others have not been able to do that, to get the talent that you need. So I'll stop
Yeah,
there.
no, it's well, of course, it's just boyish charm, it's like it's like no, seriously though, it's I do think that the mission is really resonant with a handful of people that are working in more tech related sorts of spaces. And there's a direct analogy of kind of like moving things over, but also there's been 20-25 years of kind of work in this space of trying to use analytics, trying to use modeling, and trying to use different sorts of algorithmic approaches to understanding how we're benefiting from going forward. And then also it's like, I think one of the things that really helped us out though too, is that people were seeing how serious we were about actually building this organization. And part of it too is some people were really attracted to building a whole new organization and that kind of internal to government startup, which is going to be slightly hard to replicate in other ways. But and then the last thing I would say is that once people started seeing the quality of people that once we got that initial nucleus, we started seeing a snowball effect. And so I think that's part of it. So a little bit, I don't know if there's a lot of generalities that could be pulled off of that, but I'll think a little bit more about that. Yeah.
I think that's great because I just feel like there's others could benefit from
Yeah.
things. If there are things that are replicable, that it would be great to share it. I guess the other thing would be this look at retention too, how
Yeah.
able you are to retain over time, because that may be a place where things fall off
Yeah.
after the novelty.
One thing I will say though too is that Congress gave us the authority to do direct hire. That was a huge benefit. Once Congress gave us that, we hired 10 people like that. That was a huge benefit, number one. And another thing too is having ability to hire remotely really enables us to hire quality people that are struggling with kind of like the two body problem in an academic sense. And so it's that has been, both of those things have really enabled us to hire quality people in a big way.
So those things are things that could be replicable. it
Yes,
seems
those
like.
things definitely
Yeah,
could be.
yeah.
Yes.
So I have another question too, which is a little bit different. I'm on the data and surveillance working group, and the terms of reference that we have now is very specific about us helping to inform data modernization as you're trying to streamline the data sources
Yeah.
that are coming in. And I'm listening to and hearing all these data sources, and I'm thinking, oh, my head is splitting because part of the goal is really to streamline
Yeah.
and simplify. And you're talking about other and new and novel data sources. So I'm just wondering how you're thinking about that as we move forward, because I think that what Dr. Cohen has described is a real need to be
Yeah.
clear, to be supporting the systems that really benefit the whole agency and the nation, and not just doing things because that's the way they've always been done. And so I'm curious how you're engaging with the data and modernization initiative to make sure that we're not just adding additional.
Yeah,
strings
no,
there.
Jen and I talk repeatedly multiple times a day, and we work very close with the Office of Public Health Data Strategy, Surveillance and Technology team. Very, very close with them on trying to make sure that we're coordinated and connected. I think that I often say it's like, I think what's going to enable us to be successful is the degree to which we can work with state and local jurisdictions and effectively work with them and provide them tools that are successful. Also, the public health data strategy has to succeed for us to succeed. It's critically important. The degree to which they succeed means the degree to which we'll succeed going forward. Now, we'll always be able to extract more information out of data that are existing, but more data is more better. So it's is pretty much what it comes down to. But I also, going back to Jill's comment though, too, it's like, I do think over the next 5 to 10 years, we are going to see a much more fragmented data system within healthcare. I don't, unless there's something like what we saw, I think there was a glimmer of hope in here though, too, is what you saw with Apple and Google working on exposure notification. Now, regardless of how you feel about exposure notification, there was a huge success in that Apple and Google created infrastructure at the enterprise level to make that even possible, that we could even conceive of talking about it. That we need to find ways to actually aggregate on a level that we haven't seen before. And it goes against business models in trying to monetize data in different capacities. So we need to, it's going to be, I think, a hard slog for the next while to try to take advantage of the things that Jill was talking about. Yeah.
So that was going to be one of my questions, is how are you thinking about working with the private sector, and what would help to build those kinds of partnerships? And what would you need to make that actually work?
Yeah, no, as I mentioned, I was recruited out of the private sector to come help build this organization. Our chief technology officer is Eric Rescorla. He was the chief technology officer from Mozilla. He came over to help us build what we're building. So we've had some success in working with the private sector to actually build things going forward. I do completely agree with you. We need to think about how do we actually use different mechanisms to pull in private sector capabilities beyond just the standard sort of contractors going forward in different capacities. And so we've been looking at a handful of different authorities that we could look at, like other transactional authorities, and some, I'm forgetting the name, SBIR. It's a small business in innovative research investigator.
Yeah, and
Yeah.
I'm thinking less about the development of technologies, but more about how to harness some of the things we're talking about, so that the fragmentation, you're
Great.
thinking about upfront, how to reduce that fragmentation.
Yeah, no, that's a great question. Like I said, I in the beginning of the pandemic, I was working in the private sector, and we had a lot of conversations with Apple and Google and a handful of other groups that were trying to build that infrastructure that would allow us to actually do things for exposure notification. But we do need to do more in that space.
Yeah, I'm just
100%
wondering
agree.
whether there's, a broader strategy that needs to be put
I think you're
into
right.
place, where there's actually at a higher, at a
Yep.
higher government level, perhaps even departmental level, thinking about, making some of those very explicit agreements. So anyway, the other was just, this is incredibly inspiring. And as I think about, part of what we're all interested in is how do we continue to build CDC's credibility? And I think this gives a lot of credibility after a time where people felt we didn't have that kind of capability. So communication strategy, how are you getting this out beyond state and local and territorial and tribal health authorities, but really thinking about how do we use this beyond just the impact that it's going to have on, disease prevention, to really think about bringing and building that kind of trust in public health science.
Yeah, no, I thank you for the compliment and also for the challenge, because we completely agree with you. It's like in my ill-spent youth, I worked at the White House in the Office of Science and Technology Policy, and where we were thinking a lot about how to develop this capability. And Louis Uccellini, who is the director of the National Weather Service at the time, he told me this really great story about how they had these beautiful models for tornadoes and other severe weather, but they had terrible ways of communicating the modeling results, to the point that some of their risk communications were actually putting people in harm's way during tornadoes and that sort of thing. The message that Louis was trying to teach me more than anything is, it's like, you can have the best model in the world that will tell you exactly what's going to happen. If you can't get people to understand it and communicate it in such a way that it actually elicits the behavior that will protect them, then it doesn't matter how good your model is. And so that's one of the reasons why we have spent at least a third of our effort trying to figure out how to communicate the results more effectively. And so I'm very much aligned with you in terms of figuring out how to communicate those results much more effectively. Yeah. Yep. Exactly. Yep.
Two more quick questions, first from Rhonda and then from Joe.
Mine is going to be really, really quick, Dr. George. I don't know if you've ever heard of me, but now that I've heard of you, I think I might love you. What I do love is the body of work that you are addressing and how you are doing it. And when you were talking about, bringing private industry in, the other part of the private industry are the healthcare providers and the healthcare payers. And I wish I could be there to hold your hand, but I'd really like you to make sure that you're going to have to talk to them and you're going to have to bring in some of the early adapters to kind of help you work with it. Otherwise, all the genius, all the fantastic forecasting that you're able to do may not translate into a clinician, a health benefits program, et cetera, being able to address what is in the data. So at some point, there has to be like a bridge. I know you know it, but I'm here to ask you not only to make sure that you figure out when and how you do it, but in the meantime, please don't lose your focus.
Yeah.
Please
Yeah.
don't lose the task at hand, because you've been at the White House, you've been in politics, you've been in all that other stuff, right? So you kind of know that people will try to use the things that you have built for other purposes. Please don't lose the focus, because this is what we really need right now, is what you've got.
Well, thank you for your comments, even though they made me blush a lot. So it's really appreciate that. One of the things I did want to highlight with you as well, though, too, is that over the last 2 years, we've been working with the University of Utah and the University of Utah hospitals in the Intermountain West hospital system. And one of the things that was really exciting about what they developed is during the pandemic, they were actually able to use their electronic health record to give a situational awareness as to what was happening in the hospital. They were working with the university to generate forecasts based on that data to help them understand what was going to be happening over the next handful of weeks in their hospital. They use that information, the combination of both of that information in a couple different ways. They could figure out absenteeism of their clinical staff, their nurses and their docs, how much they would have to backfill. They were also looked at how many heads and beds they were going to have from COVID. And then that determined how many elective procedures they could do as well. Then they also used it for scarce resource allocation for Paxlovid and vaccines in the early part of the pandemic. This was an early example of how we were actually trying to work with healthcare to make these kind of really granular decisions. We are working with them. They are one of the members, one of the awardees in our network, and we want to see if we can scale that. But would love to work with you and get any other feedback as to how we might work that, scale that more effectively. Yeah.
Yeah, that would.
Oh, you're on mute, Rhonda.
It's probably good you're on mute right now, because I'd probably blush some more about it.
No. I've been pinched and told not to tell you that I love you. But anyway, but I've already said it, so you already know it. But what I wanted to say is, when you're working with healthcare, you're working with the providers, work a little bit with the plans too, because they do have data that can be used to give you sentinel information, right? Particularly pharmacy data, antivirals use, right?
Yeah.
When we watch the antiviral prescription use go up in small counties in South Georgia or in the west coast of Florida, we can kind of tell that the physicians are seeing something.
Yeah.
Something is going on and is picking up, but that's another thing that can be added to your arsenal of information that you have. But great job, and thank you.
Thanks, Rhonda. Very last quick.
I promise I'll be quick. So we've got a communication issue and we've got a manufacturer's incentive issue. Okay, manufacturer's incentive. Think about Radex. They seem to be moving beyond infectious diseases. I know they had a maternal health challenge, also ARPA-H, and maybe for a disease or disease situation that's non-threatening to the individual. So, pick a target, and if we could incentivize using those programs, manufacturers in a particular area that's less individually threatening, is that a way to go?
Yeah, no, I think so. I think there's something there, and it would be great to talk with you more about that particular proposal. I know that, the diagnostic space is challenging, given the regulatory kinds of requirements associated with going through the whole process. And then also the business model is challenging too, from the standpoint of it's like, the return on investment is not what it is for therapeutics or for vaccines. And so it is a tough space to work in, but I would love to follow up with you on any of those kinds of thoughts. Yeah.
Thanks very much, folks. We're going to go ahead and break for lunch. We've avoided the computer shutdown during the session. And so we'll reconvene at the top of the hour. Appreciate you being here.
And lunch is our next door.
For having me. For those of you I haven't met, my name is Kate Wolf. I'm the Chief of Staff here at CDC. Coming up on my 1 year anniversary, which is kind of mind blowing. But I think, as many of you know, one of the key roles that I was charged with when I started a year ago was the continued implementation of CDC Moving Forward and all of the tremendous effort that we had started over the summer and fall of 2022. I think this group was able to hear from Mary and Jim late in 2022 about the work that they had done to bring folks together, both internally in CDC and external partners, to really take a look at those lessons learned from COVID and help us get set up for the public health agency of the future that we really want to be and need to be. Part of that work was creating priority action teams that were made up from folks all over the agencies who put forward recommendations on discrete actions for CDC to take and implement over the course of a couple of years. So right now we are in the middle of that implementation process. So if you go to the next slide, I guess you're just telling me that I need to say next slide. As a reminder, these are the 7 main core areas for improvement, plus the integrating health equity, which is, as Mandy was saying, really embedded across all of these areas, as well as being called out on its own. So we ended up with about 160 discrete actions that are bucketed in all of these areas. And I'm really excited to tell you that right now we've completed more than 75% of those actions, with the remaining 25 on track to be completed over the course of this next year. Some of the actions, and I'll talk specifically through some of the critical areas, but we have things that were, sort of one and done pieces of, like changes to a specific policy, or making sure that the right communications people were involved in the right response activities, those sorts of changes internally. We also have a lot of actions that are requiring ongoing implementation efforts. So we are monitoring the implementation of those actions, continuing to iterate as appropriate, and then just as Mandy discussed this morning, really looking at the next chapter of moving forward to be that strong foundational base of operational excellence across CDC that will help us really succeed in the priority areas that we've identified as an agency. The other component of moving forward was the some of the reorg work that happened a year ago as well, where we were elevating offices, creating more cross-cutting work to try to break down some of the silos across centers. So happy to talk more about that, but I think you have heard about that in previous meetings as well. So if you go to the next slide, I just want to sort of tick through some of the highlights of the work so you can see where Moving Forward has been demonstrating a value add to work that we are doing across the agency. So one of the places that really came to light through the process that Mary and Jim and others worked through was to make sure that our we're getting science out faster. This is something that Deb and team have worked very closely on, and with our team at the Office of Science. And the clearance process is a place where we're really seeing the improvement here. Our process now has allowed us to cut review times in half. And we have improved, we have a 120% CDC-wide improvement in our clearance rate. So we're really proud of this. And then I think the other place that you're seeing this is other ways that we're communicating science. So as part of our respiratory virus response this fall, we were posting weekly updates on our website of, you know, here's what we know about the latest variant, or here's the latest update about vaccination. Here's what we're seeing in the data. So really trying to use all of the tools that we have available to us to communicate the science that we have. I know that you all have been closely involved in the work around improving our lab capacity, quality, and safety. And I really want to thank the work that this committee had done in that space, that those recommendations from this group were what was rolled into the Moving Forward work as our action. So this is a place where we do still have some ongoing actions that need to be implemented, because we want to get this right and we need everybody to come along. So we're really making sure we're taking the time to do that. But one thing that has been implemented is the electronic quality management system that's part of the broader laboratory quality plan. So we are happy to have this piloting right now the software to manage this system for a phased rollout across the agency in 2024.
Let me interrupt you just for a
Yes.
moment. I see that Josh has raised his hand.
Yes.
I'm not sure if he is on or is he trying to get in? Oh, no, but he raised his hand. I was wondering if he had a question about the lab piece. Okay, never mind.
Okay. Josh, just raise your hand again if you need anything. Okay. And then the third place here, last fall, we rolled out our public health guidance framework. Again, trying to get at that recommendation of how do we translate our science into implementable, understandable, and meaningful public health guidance. I know Mandy talked a little bit this morning about how that framework is being applied and working well in many of our areas today. Some areas we have some work to do, but it definitely is the direction that this agency is going to take going forward. If you go to the next slide. So clean slate, another area that Mandy mentioned this morning. Again, our website has hundreds of thousands of web pages on it, and we have been working really hard to go through every single one of those to make sure that the information that we have available to the public is useful and meaningful and appropriate for that audience. We are relaunching our website here this spring, and so we'll keep you all posted as those websites get updated. But we're expecting that we'll have a reduction of at least 64% of our current content as part of this process. And to not raise any alarms, so we are archiving everything. So we will still have everything available. And so we can go find anything that we would need. But at least we expect that this will really enhance the usability of our website for a broad public. We're also really excited, the workforce piece of moving forward is a critical component. And internally, we have launched CDC Ready, which is a platform that we are using to organize ourselves for a response. So this is really a cool tool. Every single person at CDC is able to create a profile within the CDC Ready system. So when we have a response that we need to be deployed for, we're able to go find the right expertise and skills from the right places to help put them at the forefront of the response. And then the platform also allows us to, for those who are participating in the response, to have easy access to the data, the reports, everything that has come before. So it really reduces the administrative burden of joining a response. So we're really excited about that as well. And then the last one on this, I know that Les was here talking with you all today, but really appreciate her leadership and Leandra's leadership in thinking through our public health infrastructure grant. This again is the way that we are trying to build the public health system that we need across the country, not just here at CDC, and making sure that our grant programs are aligned with not only the workforce needs that we have, but the goals that we have around equity in our workforce as well. On the next slide, I know you have also heard often from Jen Layden. So modernizing data is a huge effort as part of moving forward. I know you all are very familiar with our electronic case reporting and how we did not have it before, and we are really working closely with the team to improve that. And now we have more than 28,000 facilities across all 50 states using electronic case reporting. So that really helps our data efforts. I also am really proud of the team sort of connected to this area, plus the communicating science faster. You have seen that we made some improvements to like our wastewater visualization and dashboards. So how can we harness the data that we have and make sure that we're getting it out to those who need it quickly and in a usable format? And then finally, one of the other big components of moving forward is how we are across the agency creating and building results-based partnerships. So the best example that we have for this is how we are using the collaborative initiatives that I know Charlene came and talked to you about last year. And then you saw again reflected in Dr. Cohen's priorities that she talked about today, that this has been a through line for us for a while now. But we have specific projects that we have identified in these three bucket areas that are targeted at results-based partnerships. So how is CDC bringing our expertise and resources to the table in these areas? And then how are we measuring our success and implementing what we've learned from that? So we're really excited about using this as part of this next phase of moving forward to really demonstrate how partnerships are essential to all of the work that we do across moving forward. And then our last slide here, just wanted to give you a snapshot of just where we are in the timeline for moving forward. So we are, as you can see, squarely in this implementation phase and working, as I mentioned, to make sure that we're tracking and monitoring either the use of new processes that we've put in place, making sure that we're having conversations with our CIOs about how things are going. So if there's anything else that we need to iterate on or continue to update, that we do that. And then really thinking through how do we build on the successes of moving forward to make that one CDC enterprise-wide foundation as strong as it can. So whatever the challenge is that gets thrown at CDC, we have that really strong base to launch from. And I think that was really the point of moving forward, right? Of like, how do we break down some of those silos, make sure that we have those strong connective tissue across our CIOs So whatever it is that we need to do next, we're prepared to do. I'm happy to answer any questions. I will tell you, Jamila, who's been here with us today, has been a huge supporter and help in implementing all of this. And that we really do have leaders from across the agency who have been, like Leandra said, who've been in, elbow deep with us as we've been trying to get through these actions. But the biggest challenge, and I think you heard this a little bit from Mandy this morning too, is some of this requires massive shifts to the way the agency works together. And so these actions, our discrete actions, are important and they needed to happen, but we can't take our foot off the gas, and we need to continue that now to demonstrate how these changes that we've made are a value add and helping the agency as we move forward. It's impossible to talk about this without saying move forward. It's very difficult. So maybe I'll stop there and see if you have questions. What else can I share?
Well, it sounds like the initiative was well named then. Huh?
Yeah.
And can we just remove the slide so that I can see who in our virtual audience is there? I know that Josh, in theory, Josh had connected, right? But it doesn't look like.
I'm here. I'm here. Can you see me, David?
I cannot see you. No. Yeah. There you are. All right. All right.
Well, now that you've noticed me, let me just say I thought that's great. And the moving forward work is really fantastic. It's really hard to do internal projects like this when there's so many demands from the outside world happening at the same time. But it's just incredibly important for, fixing things that have been problems before and setting a strong, platform for doing all kinds of things in the future. So really, really appreciated that presentation. And I know how hard it is to do that kind of work.
Well said. Jill, is your card up or is that from before lunch? Okay.
On all the work that you're doing. One thing that the lab work group raised when we did the evaluation in our first project was the structure of the IMS in emergencies, and that that was didn't seem smooth at best during COVID. Now we're working towards one CDC. I assume you'll still keep the graduated response, but how is the IMS going to be structured?
Yeah, that's a great flag, and is something that we are actively looking at right now related to the graduated response framework, because it does, in some ways, box us in, right? As you know, when it gets implemented. So, this year, just as an example, when we came out of the public health emergency last spring, coming into this fall and winter respiratory virus season, we as an agency were thinking about how do we organize ourselves when we're not in an emergency, but we have an issue where we need all hands on deck and across agency systems. So what ended up happening, and what I think worked well, though I know we need to make some tweaks as we think about it going forward, is that NCIRD set up a respiratory virus response group. And that included all of our enterprise-wide functions, so data, lab, science, comms, OKU, our operations folks, Leandris, and our Office of Health Equity, plus the flu team, the COVID team, the RSV team, plus Les's team, plus all of senior, everybody was really invited to sit at that table and participate. And it wasn't a formal response structure. Like there were pieces of it that mirrored it. Like we ended up setting up, a channel for our comms folks, right? To make sure that everybody was getting the communications materials. We had regular meetings that went through a sit rep, and then here's the issue, so learning some of those lessons, but sort of without as much of the formal structure of an IMS system. And I think that worked well for us with the one caveat that this is an agency that when something says response in the title, they feel a certain way about it, right? And you behave a certain way. So we're going to work through some of that going forward, but that all hands on deck on something that wasn't technically an emergency was somewhat of a new feeling for folks. And I think we learned a lot of good lessons there. That's all to say that we're trying to think through now the graduated response framework and see if we can figure out how we make that fit. And similarly thinking about the MPOX response, and now thinking about the next MPOX response, like what's the right way to lean in, make sure that we are organized and prepared and leaning in. So we're ready should we need to go into that emergency phase in a way that is not, everybody's not constantly in an emergency response. So it's a tough balance. I don't know, Deb, if you want to say anything else about that.
No, I mean, I agree with what Kate said. I think we're just trying to get past, people react to the word response as well, because we've heard from some of our staff that get PTSD when we're talking about response because they feel like they've been in response for a bit. So how do we more routinize it and be prepared? And so I think that's what we're trying to do, is make sure people have enough awareness, but it is being more programmatic in nature where we can.
The other important thing is that the people at the executive level of the IMS need to know everything. That there's an expectation that some things will go wrong, but you need to know about it so that you can do something about it. And that's people take pride in their work and don't want to admit that there's a problem, but
I think
there
we've
will
learned a
always
lot,
be a
though,
problem.
from our prior missteps.
Well, and I think that also requires leadership, knowing when you hear a thing, everything can't always be a crisis too. So that, I think it's something that we're working on multi-directionally.
Kate, thanks so much for the update. It's incredible progress that you made on this, especially given that there was a transition in leadership. I mean, right in the midst of moving forward, you have a change in leadership and you continued the work. So it's really impressive. I have a comment or maybe question that builds on what Jill was talking about, because I think Mandy described the siloing that's happening within the organization. When I hear about the goal of one CDC, to me, it's like this breaking down these silos, not just in a crisis or in a response, but just a baseline. And I think actually the silos, my experience, break down more easily in the crisis because it just doesn't make a difference. Everybody has to pitch in and everybody does what they need to do. But the challenges with the siloing is really much greater at baseline. And it was interesting when Deb and Allison were talking about the mental health work, I thought was really interesting is you clearly defined your roles. Deb talked about the agency-wide type of priorities, and then Allison talked about this, the center's priorities. And I'm wondering, but Deb can't do that for all issues within CDC. Are there people like Deb who are thinking across the organization for the different public health priorities? Because I think that is having a responsible person who has that kind of organizational perspective really can help to break down some of the siloing that occurs. So just curious if that's in place or if you're thinking about something like that.
Yeah, no, that's a great question. And I will say, kudos to, Dr. Cohen for coming in the middle of this and, really picking up the ball and running with it. She was very clear on her first day that she saw the direction of moving forward and wanted to make sure that it was continuing under her watch. And I think you can see how it is evolving in a really healthy and productive way as we are continuing to go through this, that, thank goodness Dr. Walensky got this going, because that was the hard part, right, of identifying the problems. And so we've just been, I think, really lucky with our leadership that we've been able to keep this going. But you're exactly right that we can't just work together in a crisis, that we have to work together always. And so what Mandy didn't get into the details on around her priority areas today, but the way that that is being executed is that for that readiness and response bucket, for instance, there is this afternoon a meeting where we have a leadership meeting on the readiness and response priority area. And every CIO director is invited to that, or, they can set, that's a lot of meetings, so they can send a deputy. And so there are critical people who have been identified as leads on different components of that, but everybody is at the table and has visibility and transparency onto what's happening in that area. And then also, you're at the table, and so you can get tasked with part of the work, as needed and as appropriate. And that's the way that that has been set up for all of those priority areas. So, we are, and it gets even more granular in those collaborative initiative pieces too, right? Where we're bringing in folks from outside of CDC to sit at that table. But you're exactly right that the way that Mandy is really thinking about those priority areas is that everybody should be at least read in and knowing where we're going in it, and potentially really have a thing that they need to do in those areas. So Mandy for sure is the one person. And then I think that all of our leadership in the IOD and across the centers are thinking that way too.
Two questions. One quick one, I think, on the point that you were just talking about. These things work best and maybe work only if there are dedicated staff beyond just CIO people who show up that can actually serve as the nidus for the momentum to continue. Are there dedicated staff? Have you been able to find a dedicated staff for these activities?
Yeah, so this is another place where, Dr. Walensky was able to find us resources when we got this project kicked off. So in our Office of Chief of Staff, besides this being part of my performance plan, and I'm accountable for this, we have Jamila who is on my team and helping with that. And then we also have other staff who are helping us with the project management pieces of it and some of the other communications as well. Yeah.
Maybe the longer and maybe unfair question, because we've heard this morning that CDC can have only so many priorities. On your results-based partnership, there are a couple of areas that I would highlight: health equity, equity, and climate, where even within our recommendations for equity, we said CDC needs to engage in partnership beyond HHS with other federal agencies in order to make that happen. And certainly that's true for climate as well. I'm wondering if you could talk with us at all about the extent to which you're able to find the resources to engage with Department of Transportation and HUD and USDA and the other non-HHS agencies that are critical for your success in those areas.
Yeah, I would say that some places we have a head start more than others. During COVID, especially, there were a lot of engagements across the interagency because things that we were doing at CDC had an impact, across. So there were some good connections built. And then I would say also when it comes to like USDA, that we have a lot of different parts of our CIOs are engaged there. But certainly I think there's an opportunity at a leadership level to sort of deepen that work. So we have sort of the food work happening in one place, and then we have sort of the animal health, One Health work happening in another place. But I think there's definitely opportunity there. And then out of COVID, I think we have a great relationship with our Department of Ed partners. So, we talked a little bit about some of the school-based mental health work that's happening, but then there's a lot of other school-based public health issues that we have good connections with. But it's a good place, a good question, and a good place for us to continue to move forward. I do think on some of the heat and health, we've got some good opportunities with our NOAA partners, and like thinking on the weather side, that's a really strong relationship that we're looking to capitalize on really with that work this spring. And then, I think we also have more work to do within HHS as well. You know, we have on the behavioral health side, I think there's really strong relationships, but this bucket of work of integrating public health and healthcare, you know, that is a place where I think we have a lot of ideas and ways that we can better connect with our CMS and HRSA colleagues.
Thanks. And don't forget HUD and DOT and.
Yes, I did write all of them down.
Yeah, just building on David's comment, I was having flashbacks to my time in Chicago where we were engaging with other city agencies. And the way that we got a foot in the door was often by way of the data, because we had the data and that was something that the other agencies valued and wanted. And so while it may not have been what we were wanting to get out of the agency, it was a way for us to get their attention and maybe engage in conversation. And that's something that CDC has an abundance of, and expertise with the data and scientific knowledge about it. That just seems to me there's plenty of opportunity. And as we talk about structural inequities that lead to poor health outcomes, engaging with these other agencies is critically important because they play such a major role in terms of the health outcomes of folks downstream.
Kate, thanks so much for taking the time today. We really appreciate it, and just want to echo the appreciation for the remarkable progress that you've been able to make. It's spectacular.
Yeah, we're getting there, and I'm excited to come back next year and tell you that we've checked all of those boxes off and that we're really moving things forward at the baseline as part of One CDC. And thank you all.
Later this year.
Well, we'll work on the lab stuff. But I also want to just thank all of you for doing this work with us. It's really, really helpful and important to have partners and champions and sometimes critics sitting at the table with us. We really, really appreciate it. So thank you so much.
And can I just jump in there and say you need to advertise what you're doing?
Yeah.
I mean, we wrote a Scientific American on your progress. It's good progress. We did say what else you needed to do, but you know, tell the world about what you're doing. Really, you're making great progress.
I'll take that back to our comms team. Thank you all.
Thanks a lot. Okay, we're going to move forward. And next on the agenda is this. We are working towards an earliest possible adjournment. We'll see how we do on that. But we have committed to receive a report on health equity and equity at each of our meetings. And Leandris has been gracious enough to provide those to us. So Leandris, you're on for talking with us about some of the work in progress since we last heard from you.
Thank you so much, David. Good afternoon, everyone. First of all, I'd like to acknowledge the ACD for their leadership and contributions in laying out recommendations to enhance and accelerate CDC's efforts to achieve health equity across its broad portfolio of public health science and programs. And for any of our new members, I want to give a quick summary of the process. The now sunset Health Equity Work Group of the ACD put forth action items across 3 task areas, which I will describe in my presentation, which were then adopted as recommendations by the ACD and subsequently acknowledged by the Secretary of the Department of Health and Human Services. The Office of Health Equity was then tasked with leading the implementation of the recommendations in close collaboration with the National Centers, Institute, and offices of CDC. During the last ACD meeting in November, I provided a brief overview of CORE, which is CDC's Health Equity Science and Intervention Strategy. And I also described some actions that were underway to incorporate the ACD's recommendations into CDC science programs and policies. And today, I will discuss our continued progress and accomplishments and reflect on the work that remains. So if we could go to the next slide, please. the Office of Health Equity was launched in 2023. And let me say that it builds upon the agency's 35 years of a focus on certainly racial and ethnic minority health. And the office exists to ensure that health equity is embedded in an all of public health approach to overcoming persistent health disparities and health inequities across a range of population groups that disproportionately experience poor health outcomes. And this work is done in collaboration with the National Centers Institute and offices across the agency. So in standing up the office over the last year, we identified 5 strategic imperatives as part of our much broader strategic plan, highlighting priority goals and major activities through the 2024 calendar year. We're using this plan to pursue our mission and guide our day-to-day work to advance health equity. So the first imperative is strategy. And so if a commitment to health equity is going to be successful, we must institutionalize its principles and practices and align agency-wide initiatives to accelerate progress toward achieving health equity. And toward this end, we have developed an office-wide strategic plan. And that's one of actually the moving forward deliverables that the agent, that our office submitted actually last year at the end of the year. And also including a multi-year roadmap and metrics that integrate health equity, social and structural determinants of health, and diversity, equity, inclusion, accessibility, and belonging. And this is the foundation for creating long-term change within CDC to advance health equity. If you look across the additional 4 strategic imperatives focused on funding, partnerships, the public health workforce, and science and interventions, we are operationalizing the recommendations that were approved by the ACD. We have intentionally aligned the activities within these imperatives with the ACD's health equity recommendations, and I will highlight some of our progress in the next few slides. Next slide, please. So consistent with the task area 1, CDC recognizes community engagement as the cornerstone of good public health practice. And our partnerships imperative is focused on increasing community engagement with populations that experience health disparities and health inequities. For more than a decade now, the Office of Health Equity has collaborated with public health organizations such as ASTO, NACCHO, and more recently, the National Association of State Offices of Minority Health to promote health equity. And last year, we established and convened a collective of public health leaders representing state, local, and territorial departments of public health, and established what is now known as the Power of Partnerships Health Equity Alliance. This alliance is a forum for problem solving and information exchange as we work to integrate and institutionalize health equity into the day-to-day practice of public health. The Office of Health Equity is continuing to expand our partnerships with the state, tribal, local, and territorial organizations through our continued collaboration with our new Public Health Infrastructure Center, which is now also a collaborator in the Power of Partnerships Alliance. And so by aligning ourselves more closely with the Public Health Infrastructure Center, we seek to improve and increase community engagement among departments of public health. Our office has also developed an overarching health equity partnership plan to facilitate the strategic engagement of partners. And again, since our last meeting in November, the office has convened meetings with multiple organizations that prioritize racial and ethnic minority groups, including the National Medical Association, the National Hispanic Medical Association, the American College of Preventive Medicine, a community-based organization called Choose Healthy Life, and another organization called Proceed that is focused on Hispanic and Latino populations, among others. So there are many more that we've interacted with just since last November. And in these meetings, we have sought to determine how we might be able to collaborate more closely in the future. In 2023, our office launched a series of health equity partnership webinars to bring together an intersectional collective of health equity organizations that focus on a range of populations, including racial and ethnic minority groups, people with disabilities, people who identify as LGBTQ+, and more. So public health, healthcare, and other partners joined the partnership, and hearing from both CDC and external partner programs, we're able to increase our collaborations, increase knowledge sharing. So just in the 2 webinars we've organized, over 2,500 partners registered and over 1,300 actually joined us. So one of the ways that we've been supporting the larger efforts of Dr. Cohen's priorities, we reached out to more than 70 community-based organizations and national minority serving organizations to share with them the respiratory virus season prevention messages, and to then get back feedback from them about how we could do that even better as an agency. We took their feedback, did a thematic analysis of what they shared with us, and we have shared that with NCIRD, and they are, working to address those challenges. I can tell you, we had some work to do in terms of improving those methods. Next slide, please. Okay, so task area 2 calls out the impact of CDC's organizational structure and how it affects the staff's ability to really pursue health inequities. Because of the tremendous role and responsibility that CDC has in instituting and supporting public health programs, projects, and activities through resource allocation and program guidance, we have a strategic imperative on funding that is focused on ways to expand the integration of health equity in this area. So through CORE, over I think a couple of years, we convened health equity SMEs from across the agency to figure out how we could incorporate guidance around health equity in the non-research notice of funding opportunity template. And so we are pleased that after that process, we have been able to put forward health equity considerations that will cue the NOFO writers to address health equity in the design of their NOFOs. And after being published for competition, it should cue the applicants to address health equity in framing their programmatic response. So our office is working closely with the Office of Grant Services, and we'll be launching a training series actually in the spring to help to socialize the health equity guidance that is now part of the NOFO template. I know that Dr. Dauphin mentioned this earlier, but I just want to reiterate that at the beginning of February, CDC posted the full notice of funding opportunity for the strengthening public health systems and services through national partnerships to improve and protect the nation's health cooperative agreement. And we see this as really an important opportunity for community-based organizations and national minority serving organizations to compete for resources from CDC. So in mentioning this new cooperative agreement, we welcome your assistance to help us spread the word about this new opportunity. And the applications are due on April the 1st of this year. Next slide, please. So for task area 3, our office is collaborating with other CIOs to develop approaches and resources to facilitate the systematic and consistent integration of recommended practices for health equity science across the agency. So our science and interventions imperative underscores the need for equitable, community-informed approaches to advance health equity in research, surveillance, evaluation, preparedness, and response and laboratory science, all things that you all have heard about today and will continue to hear about. So we're working closely with the Office of Science to increase awareness and application of the health equity science principles that was also published in public health reports. So we feel very good about the rigor of those principles and the ability for scientists to really apply them. Next slide, please. So as the agency's health equity champions, we are working collaboratively across CDC to achieve key milestones toward the advancement of health equity. And the ACD's health equity recommendations provide a framework for how we may chart additional efforts that will accelerate movement toward health equity. We recognize that health equity must be at the core of developing any intervention, innovative solution, policy, or programming for populations affected by health disparities, including the authentic representation and inclusion of community members and community-based organizations. And so as we look ahead, CDC is taking steps to shift how CDC conducts its public health research, surveillance, and implementation science through innovation and collaboration. And in addition, we are working to integrate health equity considerations in funding to address drivers of health inequities. We recognize we must recruit and retain a workforce that represents diversity in academic disciplines, in lived experience, and is prepared to do the work that will reduce and ultimately eliminate health disparities while also ensuring people have the opportunity to attain their best health possible. So if we could go to the next slide. I certainly welcome your feedback and comments, but I also had 2 questions I'd like to put before you. One of them is, given that our goal is to embed and institutionalize health equity in all of CDC's work, what suggestions might the ACD offer that was not shared in my update? So certainly we have the recommendations, we're pursuing those, but if there's anything that has occurred to you that we are not doing in response, please let me know. And then secondly, if there were 2 strategies that if implemented would both facilitate and accelerate the integration of health equity principles in our work, what would they be? So with that.
Thanks,
David,
Leandris.
yes.
Easy questions. I'm glad for those. Let's go ahead and remove the slide so we can see our ACD members. And the floor is open for comments, questions, answers.
Answers are always welcome.
Such a shy group. While people are thinking, thanks, Leandris. And I don't have the answers to your questions, but 2 thoughts. And we've talked about this you and I have talked about this, and we also talked a little bit at lunch. One of the problems we face, right, is that many of the community-based organizations that are actually most important in doing frontline work, particularly in communities of color, are small
Yeah.
and poorly funded, and as a consequence are unable to compete effectively for funding in the current funding environment and how RFPs are constructed. The solution to that is a longer one, but anything that you could do through technical assistance and or cooperative agreements to entities that could in turn subgrant to these smaller community-based organizations would be on my list a high priority, because in the health equity work group, that was one of the fundamental issues that people were bringing to us, that where the work is getting done and who it is that is doing the work is disconnected and is unable, because of business practices, to access the funding that's available. So working on that, including in your new NOFO, would be one. And then second, while action is important, we heard this morning that action is driven by data. And one of the problems I see with health equity and equity measures is that we don't have any sense of uniformity, commonality across CDC programs, such that at the front lines, different parts of health departments are working with different parts of CDC in measurement and descriptions of health equity that oftentimes don't conform with each other, even though you're working with the same communities, and oftentimes focus more on individual measures of health as opposed to community measures of health. So anything that your office could do to jumpstart the ability of a cross-CIO approach to measures of health equity that is informed by community and focuses on positive determinants at the community level would also be important. I'll get off my
So, yeah,
soapbox.
let me mention that the National Center for Chronic Disease Prevention and Health Promotion has a surveillance system that they call Places. And it's local data that is largely social determinants of health. So in our newsletter that's coming out before the end of the month, we actually have an article on Places. And so, you know, people can click on that and see the data that's available. We are also working with the Office of Public Health Data, Surveillance and Technology, Jen Layton's office, and the Office on Readiness and Response to create a set of health equity metrics that would be used for readiness and response. So there are lots of conversations going on around data. I'm hopeful that we'll start to see some implementation of that.
Anything that you can do to increase the likelihood that, for example, the chronic disease center specific measures become CDC-wide measures or evolve to CDC-wide measures is kind of what I'm most strongly trying to advocate for, because excellent measures that differ across different programs just create chaos and inefficiency and discouragement when you're in the front lines with limited resources trying to figure out what to do. Octavio. Oh, I'm sorry. I missed you.
Lost in thinking about your questions. And it's obvious, it's complicated because so much of why we have health inequities go well beyond what CDC is mandated to do. So just wondering how you're thinking about initiatives across agencies to really think about a real kind of social determinants of health sort of model. And is that happening? How feasible is it? And so that, and then just, with a focus on communities, and given the fact that there's so much pushback around anything that has to do with equity in different states in our nation, just wondering whether or not that's become more and more of a challenge as well.
Yeah, so I'll start with that question first. Yeah, it is. I mean, regretfully, both the focus of what we're trying to do and the populations that are intended to benefit from them, has become intensely politicized. But if you look historically, this isn't the first time, like this kind of, we go through waves, if you will, of more and less focus on addressing health disparities and really being able to take the courageous steps that are necessary. So I think that if I could say there be good news, is we've made lots of progress just in terms of our knowledge and our understanding and even our discussions of social determinants of health. So, there's much more evidence and all kinds of things for those who would be moved by that. So we're in a different place, but in terms of the actual investment and the resources to address social determinants of health through systems of public health, I think we still have a ways to go. What our office is trying to do through our partnership focus is to really start to engage, certainly our traditional partners, but to really move beyond that. And, we're having conversations that are informal at this point, but with, private entities that have a health disparities agenda, and to really start to think about how we could work more closely with them. But we have lots more work to do.
Yeah, and I'm thinking about, I go back to Chicago as an example and the housing and health work that was done, which would mean, a different department and working across. So I don't know if you're getting any support for doing those sort of initiatives that are not necessarily partnerships with health entities, but partnerships with non-health entities as well.
Right, yeah, so not from our office's standpoint, but this could be going on in other parts of the agency, but not in our office.
I
Yeah.
think that would be something important to start exploring, because if we really want to see a difference in health equity, it is going to take that kind of cross-departmental,
Absolutely.
whole of government approach to it. And, I think CDC should be the one that drives that.
Well, Andrews, thanks for the presentation. Couple of thoughts on your first question. I think about when you work with health equity with organizations, where are the sort of the inflection points that can result in loss of gains made with health equity? And one of them has to do with the people. So whenever there's personnel change, but especially any positions of authority where there's been a change in leadership, and it could be cross, from one unit to another, or a totally new person comes in to the CDC. I would recommend, especially for positions of authority, that it be required they come and meet with you and with your staff to emphasize how important health equity is to the CDC enterprise. In addition to that, to elevate and to keep folks accountable, because over time also has a tendency to soften either our approaches or other issues start to gain greater priority, for lack of a better term. Within that context, I'm thinking of how to keep things accountable and fresh when it comes to health equity. The fact that you're here with ACD every time is one thing. Now I'm thinking it'd be really neat if also you would have, talking about the metrics, as you identify them and they get solidified, creating a windshield or a summary page that you share with us, the ACD.
Okay.
at a high level. You know, we don't need to get into the details or micromanage, but we'd love to see what is actually happening, how do the metrics look? And as they start to see, especially over the course of time, but we can weigh in at a granular level, at that high level, so to speak. But also that it's not being only shared with ACD, but it's being shared with Mandy, Dr. Cohen, and that all the units know that. I just feel that there has to be an additional level of accountability when we're trying to make cultural shifts stick and become embedded, as to Helene was saying, across different systems and across interdisciplinary fashions. I think that is one way to keep it, you know, at a front of mind, so to speak.
Absolutely.
So, and can you tell me what was your second question?
It was if there were two strategies that have implemented will both facilitate and accelerate the integration of health equity principles in our work.
Thanks. Well, I think maybe I kind of answered a little bit of that one too. Just didn't even realize it. But I would throw that out there to consider it. I don't know what else you would need for, if that resonates with the rest of my colleagues here, the ACD, to actually help you implement that kind of accountability measures that is shared at a high level with obviously the director, but also with the ACD, because I think that would keep it top of mind.
Thanks, Octavio. Rhonda.
Thank you.
Hi there. I listened to your presentation and I thought to myself, I hope she has at least 6 clones and a whole army behind her, because it was such a wide breadth of things. And all of those things need to be addressed. It's just absolutely just ginormous. I'm used to seeing challenges and things be completely near the impossible thing, but this is so incredibly important. And you ask, what would we suggest? I don't know all the things that you have to do, okay? I can tell you that unless you pick something common that goes across all of the major leadership groups within your organization and have performance measures tied to it, and those performance measures are tied to not only their accountability, but I don't know, does people in CDC get bonuses? Probably not, but I think you kind of get what I'm saying here. You got to tie it to something. Whether you have new health equity measures or not, you can develop those with NQF, et cetera, NCQA, all those kind of folks. But at the same time, you already have information about disparities in diabetes, hypertension, heart disease, asthma, vaccines. You've got enough colon cancer, prostate cancer. You've got enough of that you could pick, I don't know, 5, 10 of those by geography, by region, by county, whatever, pick, right? You all need to row in the same direction. And so maybe there's some parts of the CDC that have nothing to do with colon cancer, but there's probably a lot of them that do, including the informatics people, the epidemiologists, et cetera, et cetera. You got to pick something, and you got to have a performance measure that everybody can see and be held accountable to. And then you got to report on that so that it is visible. And Octavius, I think, said something about being Mandy and more like as in the public, to see the progress made. I'm so sorry. I wish that we could clone you. I think your life would be a little bit easier, but you're doing health disparities of populations, and you're doing DEI at the same time. And I think that those are 2 massive jobs. And if I had to pick, I know they're both related and they both help each other out, but I would focus on the populations that are currently suffering. And I would be focusing in on those disease states and conditions that are avoidably causing suffering. So I can't speak to what you do every day, because I promise you I would bow down if I were there with you to all the things that you do. But you got to pick something concrete, and everybody's got to row toward it. And it's got to be measured and reported out. You know, paper is magic, so is electronic data. But you got to report it out so people can see it. And that's when people feel motivated to move. So even the people who are most skeptical can still see whether or not movement and progress is being made. Does that make sense to you?
Absolutely.
I only had 8 cups of coffee today, so maybe not.
Yeah. No, I want to share that we actually have moved the DEIAB team out of our office. They are
Okay.
now with the chief operating officer. And for exactly what you said, I mean, I've always argued that we had to lead with public health. We need to put before, you know, our whole purpose and why DEIAB is important is its contribution to reducing health disparities, health inequities.
Exactly right.
So we did that. That actually just happened
Okay.
at the end of January. The other thing that we've done through our core initiative is to ask the National Centers, Institute, and offices to commit to two goals that they are going to pursue and really drive toward an outcome. And so we're in that process right now. We've had 11 centers to do that. I think there were 18 when we first got started with CORE. And so we are in the process of setting up, you know, well, there is already a reporting system that goes along with CORE. So, but in terms of which, you know, metrics we will be collecting from all of them, I will be able to share that at our next meeting.
That'll be good. And if I had one more piece of advice is that we had, I don't have anywhere near the responsibility that you have now, but we had people who would pick perinatal care and psych, or they would pick cardiovascular disease and diabetes. And we would say, okay, we got enough, but we need teams to move, right? We watched as people who don't have direct contact with it as far as they knew, they kind of disengaged. And we had to pull them back in. So when we had to do the health equity and strategy, 5-year strategy, and have them focus on, we picked 10 health disparities. And then we basically said, you know what, just because you're sitting over there in finance doesn't mean that you are off the hook. You get to come not only to the meetings, but you get to participate and talk about how the financing is going to support the disparity interventions, the progress reporting, et cetera. If you're in ops and you're sitting over off to the side and thinking, well, that's not really me, it actually is, particularly if it's about making sure that people get the information that they need, that the background operations. Same thing with IT, they need to be part of your team and not a bystander. Not an observer, but actually an integral part. Do you already have that going on? Am I just?
Yeah, yeah. So we're, like
Really?
I said earlier, you work closely with Jen Layton's shop, which is also where Dylan George sits. And we work very closely with the Office of Science. And then we have, I'm going to call them discrete collaborations with some of the national centers. So
Are there individual performance measures tied to the success of those achieving those measures? Because that's, so we invite people to come to meetings and they would sit there on their laptops and be doing any other thing, but we actually tied it to their performance measures, their individual performance measures, right? So so IT gets a grade in their performance evaluations about, did your contribution lead to success? Was the overall success achieved? And that's, you know what I mean? It can't be just that they're taking up space and providing you advice ad hoc. They actually own some the accountability. So you guys can, the rest of the committee can disagree with me, but I found that people tend to pay attention and actually lean in when their performance is actually assessed based on what the overall performance measures are, right?
we don't have individual performance measures around equity for everybody's.
Yeah, so it's not as hard as it sounds, because if they are working with you on whatever areas you focus on, whether it's again maternal, child health, etc., pick something. Was there measurable improvement overall, whether or not they contributed a big or small to it? Was there improvement? They're part of the team. that needs to, you have to kind of make it so that it works at a broader level in terms of the accountability. I have people that used to report to me that did contracting. And for the life of them, they couldn't see how they were supposed to be responsible for health equity. And I said, well, you are the guys who are doing the contracting between the providers and the health plans. You can actually build into your contracts the health equity performance measures and requirements. You can build in the part about having to share data. Just look beyond the usual is what I'm saying, right? You've got people who are serious experts and smart as a whip on the disease states, the prevention, et cetera, the true blue public health, but you've also got folks in other areas of your operations who can help you and who need to actually be held accountable too. Otherwise, you're going to sit there and do everything. And I'm going to see you next time, and you're going to be shorter because you're going to be down like a little pencil. Okay. So you have to share this a little bit more. And you'll find that you might hear some things that you never thought about before, right? We had people who were contributing to our communications and engagement strategies who were working over in government affairs or working over in policy. And I don't want to shock you, but an actual CFO who actually cared and leaned in and helped us find other sources of financing, right? So just not to preach at you, but I worry about you and the team that you need to get the other folks to own some of this, and not just on paper, but in actual reality. Does that make sense?
Yeah, absolutely. And thank you for that. We concur.
Thanks, Rhonda. And we're going to get out a tape measure to measure your height, and that'd be one of our performance measures. Last comment, Julie.
So I'm gonna step back a little bit. I think Rhonda gave you some very specific guidance. One of the things I was thinking about as we were talking was that there's just so much that you could possibly do. And when you try to boil the ocean, it becomes virtually impossible to do that. And so given that you have limited resources and you are an office, a small office, one of the things to think about, and something that's we've been doing within RWJF, because we have an equity office itself, is really having that office serve more as a resource to establish what best practices actually are and provide frameworks for us to use throughout the organization. And to provide that as a resource, not expecting you to do all the work, but really you're providing best practices to the organization. And, in our conversations today, what has been lifted up pretty consistently as priority areas were data consistency and then also community engagement, because it's not something that's been done well with by any public health agency. And that's an area for needed improvement if you want to make a difference from an equity perspective. So you could really prioritize focusing in on a couple areas where best practices and share those as a resource to other CIOs to say, here, this is what I recommend. You should be considering these things. And then with your limited bandwidth, you could focus in on the CDC priorities. Because Dr. Cohen has said what her priorities are in terms of the readiness, mental health and overdose, young families, and the internal focus. And that's still really, really broad. But if you could channel your, share these best practices and really double down on those best practices being used for those priorities, it allows you to focus a little bit and not spread yourself too thin. Because I too shared Rhonda's concerns that if you try to do everything, you're not going to get anything done, and you're going to deplete yourself of all energy and enthusiasm, and we don't want that to happen. So I guess that would be stepping back a little bit. It could be you could think about that. And specifically, we have some equity competencies that we were using for individual performance management that I'd be glad to share with you if that would be helpful for you to look at and think about how, because they're not super, it's not rocket science, but it's just seeing what kinds of competencies you would want from an individual to perform to really demonstrate good equity skills, and individual performance can be helpful and could help you if you're interested.
So let me say that our approach has been over the last, certainly the last 3 or 4 years, we've really focused on creating the standards, right? So that when people say, well, what is health equity? We're going to these debates, what is it a value? Is it we say, no, it's a science and a practice. So we've had to lay that out. We've created training programs. We've tried to create the substance of what it is that we want people to do, right? And so then the next part of that is socializing that, getting that out, across the agency. And, there are health equity SMEs in all, if not most of our CIOs who are probably doing a similar thing, right? So having this kind of a single or even unifying sort of approach is tough, right? It's tough, but it's not, impossible. So, and also all of this takes way longer than you would imagine, right? So we can be, ultimately that is our goal, is to be a resource to the agency, but we have to be able to have defined what it is we're being a resource to do. So I think that's where, we can't do this all by ourselves, but we do need to be able to say what that is. And I don't think that, I think depending on where you sit in the agency, what your CIO is, like even I think about the labs now are trying to identify what health equity means for them. So so there's these dual processes going on, where we're providing technical leadership, we're coordinating, collaborating, but not, but also along with the CIOs are doing some of their own.
Thank you, Leandris. As always, a really great discussion, very stimulating. Really appreciate you laying out those questions at the end. And more importantly, as I think you've heard from all of us, we really appreciate the work that you're doing on this very important but difficult issue to move it forward. But we look forward to hearing from you next time.
All right.
Okay, folks, we're nearing the home stretch, down to the last agenda item. This is the session where we're going to be hearing a little bit about the work that's happened at CDC to draft terms of reference for a new work group for the ACD that is on communications and public engagement. And I'm happy to welcome Andy Freistad, who's the Deputy Director for Policy Communications and Legislative Affairs, and Kate Gladys, who's going to be the designated federal officer for the work group. So welcome to both of you. And I think Andy's going to start off. Is that right? Andy, you're on.
Yeah, I'll kick us off. Can you hear me okay?
Can't hear you.
Okay, great. Well, you never want to go after someone says you're in the home stretch. So we'll really energizing at this end of the day conversation. I know that you guys have had a packed agenda today. Really happy to be able to join you to talk about the proposed communications and public engagement work group. And my apologies that I can't be there in person this time around. I'm here in DC. So I'll just sort of quickly introduce this. I think we can go probably right to the next slide. I'll just quickly introduce this and hand things over to Kate, who's been doing a lot of work and thinking on this. As many of you know, my role is a newly created leadership role at CDC aimed at providing a holistic strategic leadership across the agency's communications and policy work streams. So I'm really excited about this opportunity to continue to build on our efforts to optimize effective communications and frankly, to leverage all of you and your expertise and experience as we're thinking about this really important work. We know, obviously, we've, spoken about it a lot, that this work is really central to CDC being trusted, highly effective, embedded in the larger integrated system that protects public health. And I know you heard a little bit earlier from Kate Wolf today on CDC Moving Forward. And just to sort of connect the dots, I wasn't on for that conversation, but to the extent it wasn't explicit in that conversation, prioritizing public health communications by improving how CDC interacts with the public remains really central to that work. And there's been a huge number of deliverables that Kevin Griffiths, who's on, who runs our communications work, that Kevin and his team have really driven forward huge changes that we've seen following that work. So these include things like building a new, easier to navigate website, more real-time communication about health threats, really thinking about transparency and what that means, and as well as things like plain language training for scientists and staff across CDC, so that when we are communicating, we're actually communicating, right? We're not just like putting things out in the world and sort of crossing our fingers. It almost goes without saying that the pandemic really laid bare the role of communications in protecting health. That it's the right information, it's getting them to the right people in the right way, the right time, and that there's huge implications for sort of whether and how people can use that information then to protect themselves and their loved ones. And, a note on that and the extent to which communication gaps with historically marginalized populations really continue to persist, and I think are a really important part of this conversation. This has continued to evolve, right? We are seeing communication as a really shifting ground, not just because of sort of the moment we're in public health, but also the sort of realities. People are seeking different types of content, right? Shorter form, more accessible written communications, blogs, visuals, et cetera. Frequenting different communication channels with the proliferation with digital methods of communication, and really thinking about what all that means for the ability to reach the public with the communications that we really need to reach them to be optimizing public health. New challenges all the time, including as folks are just sort of inundated with increasing volumes of information, both good information, misinformation, disinformation overall. So the challenges around really breaking through there. So with all that in mind, and it's a lot, the communications and public engagement work group is being established to assist the ACD in developing recommendations for all of us on agency-wide activities related to how to communicate directly and more effectively with the public, and in particular with a focus on reaching local communities with messages that will resonate and will have the impact that we're looking for. The work group will convene a balanced group of subject matter experts to assist in the development of advice and recommendations to CDC around these sort of effective communication goals. So the next slide gets at some of these specific goals. We know that there's a lot of important dynamics at play here, but we've identified 5 key goals that we think are most important here. So the first one you'll see here on the slide around building relationships and communicating with trusted messengers. So this is thinking about everyone from clinicians, faith and community leaders, health department officials. We know it's not the same people in all the same communities with all the same audiences, but really thinking about what those relationships and mechanisms look like. Number 2, improving risk communication practices, in particular, really particular challenges in that space. Number 3, delivering more action-oriented and focused communications to help people protect their health. So this is thinking about how are we using storytelling and how are we really thinking about what messages are going to be most effective. 4 is tailoring our messages and communications methods where we can for audiences, particularly, again, for those underserved communities. And then 5, I mentioned briefly transparency earlier, but really continuing to increase transparency by stepping up the pace of our communications, the content, the reach of our communications. So thinking about how are we using these different channels? What's the place for social media? What's the place for blogs, for TV, for emerging platforms? And how do we sort of bring all that to bear to really fulfill the promise we have made around transparency? So I'm going to stop there and pass things over to Kate from our Office of Communications. Kate's going to provide an overview of the proposed composition and the charge of the work group, as well as some next steps. And just to really thank Kate for the work that she's put into this already and the work yet to come, and for shepherding this really important work. So again, thanks for having me. Good to see you all, even if you are small dots in a distance. A couple of you I can make out. And really appreciate the conversation today. Kate,
Thank you, Andy. Yeah, thank you, Andy. And thank all of you for your work on the ACD. I've long respected the importance of the contributions that you all make to CDC. And I'm just going to have to take a moment here, y'all. Just bear with me for 1 second, but because I think every discussion of the ACD today mentioned, touched on or gave acknowledgement to the important role of communications in public health. And I've been waiting a long time to have that happen. There are undoubtedly some colleagues of mine who are on the phone, very happy to be where we are at this moment. This is a really important charge to take forward. Here's part of the why it's affirming, and then I'm going to jump to the details. Why it's affirming for me. I started my public health career as a communications director in state public health. I've worked for 20 plus years at CDC in communications. I was the acting communications director in the early months of 2020 and the last 8-9 months of the Trump administration. And it gave me a very unique perspective. I really saw close up what was working, what wasn't working, and the impact that the communication challenges had on what we were able to really, how nimble and how adaptive could our communication strategies be in the face of what the nation and the world were looking at. And so I want you to know up front that I'm honored to serve in this role. And I also want you to know up front that I am all in. Move this slide forward, if you would. So you've all received the terms of reference and hopefully have had a chance to read it in detail. And Andy just did a great job of really kind of lifting up the background and kind of why, what it is and why we're here. I'm going to go through some of the important logistics. And I'll say that the draft name right now is the Communications and Public Engagement Work Group. We have 2 co-chairs that have been identified. And so that's Dr. Martinez and Dr. Meadows. So thank you both very much. And we're looking to have the Communication and Public Engagement Work Group composition, and Andy touched on this a little bit, but looking at no more than like 15 members, but we want the breadth of comms background because that is really important. And there are different areas of expertise that we want to make sure is at the table from the communications perspective. But we also need community and partner engagement experts. We need, of course, public health and practice and the implementation piece of public health. And then we also need behavioral science and people who have expertise in working on behavior change campaigns. All of those elements are really critical to the work as a whole of this work group. So next slide. And here's the charge. Here are the potential areas of exploration. And, you know, I just confessed to how long I've been here. So I will say that it's not a terribly new set of questions. These are questions that in the communication space, we've asked ourselves and we've wanted to explore and push the envelope on many of these things for many years. What's unique and exciting now is that it is a shared sense of urgency that we get this right. You heard Andy say that the pandemic laid bare the communication infrastructure or the problems that we had. And I'd say that's like hard to say what almost an understatement it is. It's hard to capture how much of a spotlight it put on the challenges that we have faced over the years. So these are some of the questions, and it really will be an important opportunity to have outside voices who are informed and who understand this world to really help recommend to the ACD ways that we at CDC can make some much needed progress in these areas and more. Next slide. So just a few quick next steps after, of course, based on the results of today's vote, we will need to get quickly to the work of recruiting the membership to the communications and public engagement work group. So wanting to solicit interest from, of course, the ACD members and yourselves, but also know that we will be submitting a Federal Register notice to invite participants external to CDC and the ACD to join. We will be also setting up a review panel to help establish the criteria and then make the selections of membership. We have to schedule that meeting and before the third quarter of 2024, and then of course submit summary report to the ACD, and that might be summary reports to the ACD, but as that case may be, we want to wrap this up by June of next year. And I'm happy to take questions but thank you all.
Thanks very much, Kate. I think it's okay to go ahead and remove that slide so we can see the folks. I think I will first, without putting either Rhonda or Octavia on the spot, ask if either of you had any additional comments or questions or suggestions before opening it up to the other CD members. Go for it, Rhonda.
I think one of the things that we talked about in the discussion prior to this meeting was also making sure that we included preparation for timely addressing of misinformation. So it's not only what we need to say accurately, clearly, understandably in a consumer approach, we also need to be able to address the misinformation that so easily takes down and destroys the credibility of what we're trying to say. And so having somebody who has some expertise in that area is going to be really important as well.
Absolutely. The field of communications writ large is struggling with that very issue. We are not unique, although it certainly uniquely affects us. But I agree that expertise will absolutely be included in what we seek from our members.
Octavio, any comments?
It's really great that this committee is going to be put up to a vote. Work group, sorry. And I'm honored to be a co-chair along with my colleague. I do want to add that at lunchtime, as we were discussing, there are multiple levels that they get it. There's the provider level, there's the community, there's the providers, and of course, each one of those, there's subcategories, but then there's also, I think, the systems level. And I think though the focus has been a lot on communicating with the community, we can't leave those other pieces out. And so I think that's going to be really exciting. I think the 15 folks that come on the work group will be key. As Kate has pointed out, that expertise, but also I think it will definitely give a lot of not only insight and expertise, but will give a lot of credibility to the work group. That we truly are listening to all our communities to be able to address the issue. Because at least in my opinion, David, I think everyone I've discussed to, even if it was just a common person in Texas or a provider, or even talking to some folks that are in positions of authority at the systems level, this is a huge issue for everyone. Everybody's concerned. Now, some might have different reasons for that concern, but I think to Rhonda's point, the misinformation environment that we're currently in and how social media can impact things so quickly will obviously be top of mind. In addition to the other component that it's not embedded in here, but I think it is extremely relevant. And it has been brought up, David, earlier, which is this has a lot to do with trust and not rebuilding the trust of the CDC, but also rebuilding the trust that inherently exists in relationships that are respectful of each other. And I think if we take that perspective, I think we can make some wonderful recommendations for the CDC to hopefully follow through on. Thank you, David.
Thanks, Octavio. Any comments or questions from other committee members, including any comments or questions on the terms of reference? Julie.
Yeah, I was really pleased to see that relationships and trusted messengers were part of your priority areas, because I think, especially in a time when CDC has lost the trust of the public, healthcare providers, others in the nation, to reestablish that trust and to earn the trust may require some help from other trusted messengers who haven't lost that trust already. Because I was telling David and Octavio at lunch, when I first came to the health department in Chicago, the health department was not known as a source of information or reliable or trustworthy information. And so what we did is, over time, partner with the American Academy of Pediatrics, the local chapter, and other organizations that were trusted resources and trusted sources of information to help establish our trustworthiness as we move forward. And over time, eventually people did recognize the health department for being able to provide useful and important information and trustworthy information. So I just think, as we move forward with this effort, really keeping in mind who are those key partners who can be the trusted resources while CDC is reestablishing the leader.
Thanks, Julie.
Couldn't agree with
Just
that more,
to
Julie.
follow on, I'm sorry, go ahead.
I was
I'm sorry.
just saying, I couldn't agree more with that. It's always an important practice. It's a more important practice now that we, as you build trust, you maintain trust, you lose trust, you rebuild trust. There's this continuum. We know that we cycle through it, and the ability to connect with and have meaningful relationships with a wide set of partners who can carry that message with us and for us, and do so in ways that are more meaningful and more impactful to the communities that they serve. That's always the winning approach. And I think we're right in that space right now where we're having to truly double down on rebuilding.
I see that Josh has his hand up.
Sure, yeah, thank you for the great presentation. I wonder to what extent you're thinking of state and local, tribal and territorial health departments as sort of constituents in this effort. One of the things that has happened is sometimes they feel a little bit cut out of information. I don't really think so much of CDC is maybe FDA announces something and the local and state health officers don't know what it's about and are kind of scrambling to figure out, and they wind up losing people's attention. It's sort of like a whole public health is kind of a team. And so if CDC is focused on its partners, its community partners, and its messages to the exclusion of how others in the public health world are going to be communicating, it can be hard to really be fully successful. So I didn't totally see that in the slides, but I'm just curious how you think about that.
So we absolutely want the public health perspective at state, local, at all levels. So we want to have that perspective both represented in the work group itself, but also represented in the strategies of who we're trying to engage. So when you think about, trusted messengers, those partnerships with state and local and territorial and tribal health departments are just really critical relationships that we need to rethink how we do that and readjust the information sharing. Because I will say, you were kind to say that maybe it's not as much with CDC, but I think we haven't always gotten it right either, right? So there have been definite times where we could have improved communication with and to our state and local health partners.
Yeah, thanks, Josh, for raising that. You raised it more eloquently than I was going to. But I do think that, to Julie's point, many state and local health departments no longer feel like they're in that role of being the trusted messenger. So their, in essence, agenda would look very similar to this. And it's complicated, right? Because one of the keys, in my understanding of effective communication, is coherency and consistency across messengers. And so figuring out how to make that happen more effectively in this day and age is going to be an important part, I think. Jill.
So this may be totally naive, and I apologize if it is, but okay. Vaccine mandates. I often wonder how many people are objecting to the vaccine versus objecting to the mandate. And I wonder, you use risk communication a lot in there, as if CDC is deciding the risk, or public health is deciding the risk for a person. And is it better to phrase it as, these are the pros, these are the cons, you're an adult, work out your risk? Just, I don't know. I mean, what we're doing now isn't working.
Right.
So,
I will, having spent years in risk space discreetly, I will say this. It is much less, Jill, about how we think about risk and then choose to communicate it. It's all about risk perception. And we don't always know enough because of the challenges of doing that type of research in public health, but risk perception is what drives behaviors. And so understanding how audiences perceive these issues and then being able to create solutions and deliver messages and use comms strategies effectively, you have to be able to start with where are our audiences on this spectrum, and we need to know their perceptions of risk. So not naive.
Well, Kate, if I can add, I also think, right, there's not one answer to that, right? Depending on the topic, depending on the audience, depending on the moment in time, right? And so, I mean, I think that all goes, Kate, to what you were saying, but I think that's part of what this group can suss out, is like, how do we think about that in these sort of different contexts? Because like everything, right, there's science and there's art, and I think communications, and certainly public health communications is a place where they meet.
Sounds like a discussion to continue in the work group. Okay, well, I would entertain a motion. Yeah, and we can have discussion after a motion as well.
Thank you, Joe. Good segue. But David, I would like to propose a motion to the ACD that we stand up the Communications and Public Engagement Work Group along with the TOR.
Thank you. And we don't need this slide. Let's have the members back. Perfect. And did I hear a second? Was that Rhonda? Yeah.
Yep.
Okay, further discussion. Yes.
So I was just looking back, I went back to the terms of reference again, just to see, because I'm wondering, there wasn't anything explicit about most marginalized communities or most impacted communities lifted up. And I do feel like, as we talk.
I think there is, it's in the longer set of, it's tucked into a couple of the questions. I think the long version of the questions towards the end, but if it isn't there, let me say that it was at some point and we'll get it back. But it's critical that we work with the marginalized. Yeah, absolutely.
It was just my bad reading. Yeah, so I thank you for doing that. So as long as that is taken care of.
Any further discussion? If not, all those in favor of the motion to stand up the work group, please signify by raising your hand or saying aye.
Aye.
I would say, that's right. I would say opposed or negative, but everybody already voted. And so the motion passes unanimously. Congratulations. Yes. And thank you so much, Andy and Kate, and particularly Rhonda and Octavio, for your leadership here and your leadership moving forward in making this happen. We will go ahead and send out just a quick note to ACD members, as we mentioned, to solicit any interest, and in a simultaneous way. I think the Federal Register notice is about set to go, right?
Yeah, Carrie can correct me, but we drafted it. It's like with our office. And so our plan was to be able to like have it go out this week, I hope, or early next week. Okay. And we'll make sure that we send it to y'all to send through channels as well, because we want to disseminate this really widely so we get a lot of interest.
I think a communication strategy is never overpromised, so I like the next week, yes. Any further discussion on this issue? If not, thank you both very, very much. And we're now at the end of the meeting. We have 5 minutes for closing remarks, which I don't think we're going to take unless you talk for 4. Okay, she needs 2. I will take just 1, which is first off, thank you to the ACD members today for your participation, your thoughts. It's really, really excellent discussion. Importantly, thank you to Deb and the wonderful ACD support staff that we have that makes it possible. And I get a little bit of a glimpse of that between meetings, and the amount of swimming under the water, and there's a synchronized swim meet that's going on to make these meetings happen is quite remarkable. And you've been really effective. And thanks also to all the CDC leadership that was here today for their willingness to engage with us in these important discussions.
Thank you. And thank you, David. I would say David's good, always keeping me on track as well, saying, don't we need to get an agenda coming up? But I do want to echo the thanks to the team and to all of you. I'm delighted to have Dr. Gale join us. And I think everybody knows it is a process to get onboarded through HHS. We do have additional members that we hope we might have in place by the next meeting. We have been waiting patiently. So hopefully that. I know. And I did also just want to mention that on our ACD webpage, there is a spotlight on Dr. Adamora that we plan to keep there just to really commemorate her and memorialize her service. And I am always around. If there's ever anything I can do, please let me know. And if you have suggestions for our next meeting, shoot them to me and David as well.
Anything else for the good of the order? We're adjourned. Thank you.